Good evening, everyone. Hello. 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 Good evening, everyone. I welcome you to this evening. So grateful to all of you for having come to this meeting. On behalf of all the consultants of Vision Eye Center, we are looking forward to your presence, participation, active participation, so that we make it a very interactive session. This session has been planned to bring out some subjects of clinical interest in an interesting rapid-fire debate format, so that we have interesting facts brought out in a way which have a practical usage for all of us. And we are going to discuss whether the future is here upon us. I think the developments as they have taken place during the last 50 years that we have seen, or Dr. Satish has seen, or Dr. Anita has seen, in the ophthalmology have been phenomenal. But the changes that took place in 20 years earlier are now taking place in 2 years. So the future is again here upon us today, because there are so many rapid developments, and we are going to discuss some of them today with a great panel of experts on artificial intelligence, gene therapy, maybe a little bit about stem cell therapy and some other recent developments. But let us begin with invocation to God and a lamp lighting. So may I invite the President and the Secretary of DOS and past President of AIS, Dr. Anita, to please come and light the lamp.
या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता.
With that, we will immediately start with the scientific program, so that we can, and we'll make it crisp. We'll make sure that we go on only for 5 minutes with each talk and 5 minutes with discussion. And I'll request Dr. Bhalla to be please here with me for the session to be moderated, and Dr. Rajendra Prasad to be here please for the moderation of the cataract session. So Dr. Rajendra Prasad, please, for the opening session.
Thank you, sir. Thank you very much for giving this opportunity to be here with all of you in this beautiful evening. And Vision Eye Center's scientific program has already been looked after by most of the residents and the ophthalmologists, because it gives you a lot of scientific fees to all of us. So to start, the first session is on the cataract, and the topic is femtosecond laser-assisted cataract surgery the future? And our first speaker is Dr. Tushar Grover. And Dr. Grover is going to talk on, yes, the advantages are there for all to see. And this is going to be a debate between Dr. Tushar and Dr. Rohan Mehra. Dr. Rohan Mehra is going to talk on conventional phacoemulsification will stay as the gold standard. So let us see what they have to speak in favor of femtosecond and in favor of phacoemulsification, which we all are conversant with. And femtosecond laser is the new technology which we are looking for, and let's see what are the advantages and disadvantages of each technique and how to follow. Yes, Dr. Tushar.
Thank you, sir. Very good evening to everybody, and thank you for joining us today. So I'll be talking in favor of femtosecond laser-assisted surgery and why it is the future. Before that, though, a little bit about my opponent, who's an extremely close friend and a prolific surgeon. However, he loves everything vintage, as you can see in the picture. He loves his vintage bikes, he loves his fancy vintage cars. Even his parties are retro and vintage, and his friends are vintage as well. Unfortunately, however, he also loves vintage cataract surgery and is unable to change with the times. So, resistance to change has always been a part of our lives, whether it's with air travel. The New York Times had once said that a rocket will never leave the Earth's atmosphere. The Orville Wright, who was one of the founders of air travel, also said that he did not expect that man would fly for 50 years. The same with digital photography, with Kodak showing resistance to it. With personal computers, the president of IBM had once said that I think there is a world for maybe 5 computers. The former CEO of Microscope had said that there is no chance that iPhone would have any market share, and we know where iPhone is now. And also artificial intelligence, which we'll be talking about, and which was used to alter Rohan's photos that I got from Facebook. So the benefits of femtosecond laser-assisted surgery are already there for us to see, whether it's with the precise incisions that you get, or it's the perfectly centered capsulotomy that you get with the exact dimensions that you want. You can even center it onto the capsular bag. Or if it's in the ready-made fragmented nucleus that you get, which helps you reduce your dissipated energy. Another advantage is the ability to create arcade incisions for pre-existing astigmatism. This is typically revived arcade incisions now because you're able to get reproducible outcomes. So, I don't know what happened to the font here, but I think it's okay. Okay, so I think changing into the presentation here onto the projector has altered the font, but this study basically shows that you get reduced dissipated energy with flax. You get lesser. You get better uncorrected visual acuity as well, and that's possibly because of you making reproducible incisions that are precise. You're making arcade incisions as well that is correcting pre-existing astigmatism. This particular study, which shows question marks here, shows that vitreous loss has also been found to be lower with femtosecond laser-assisted surgery. So I'm unable to show the stats here because of the change in font, but this is essentially what the data says about femtosecond laser-assisted surgery. This is a study that we had done about arcade incisions being done with femtosecond laser-assisted surgery to correct pre-existing astigmatism. And as you can see that preoperatively, about 3.75% of the people had less than 0.5 diopters of keratometric astigmatism, whereas post-operatively, 68.75% had less than 0.5 diopters. And you can also see the reduction in the magnitude of astigmatism, which we also found was statistically significant. So these are some of the advantages that already exist with femtosecond laser-assisted surgery. Now, the typical advantages are also in challenging scenarios, such as when you have these hard brown cataracts where your femtosecond laser-assisted machine is able to soften the lens. It's also able to create the fragments. So separation of the fragments becomes much easier. You're able to get a well-centered, round capsulotomy in a white mature cataract, which can be challenging to any surgeon. Also, the advantages in a subluxated cataract. You can see the subluxation on the SOCT you are able to center the capsulotomy onto the bag even in a subluxated cataract, which is not easy or even possible in manual Rexis. And so therefore, once you stabilize the bag using a CTR or any other device, you're able to get a much better centered IOL at the end of the surgery. So is femtosecond laser assisted surgery perfect? Well, it is still in its infancy. No technology is perfect in its infancy. If we talk about phacoemulsification, it was introduced in 1948, but the concept was only accepted in 1967. And even then, there was reluctance to accept the technique. But we know where phacoemulsification is now. And the technique only became popular around 1980, which is almost 35 years after it was introduced, because there were a lot of innovations like the OVDs and foldable IOLs, and of course the improvement of the machines. So flax is evolving and improving further, but it is definitely the future. Thank you.
I think very nicely put, Tushar. You have very nice, intelligently utilized the studies and given the facts which were in your favor. But let's see what Rohan has to say. I think he will also use the same studies, but he'll give us different statistics altogether.
At the outset, first of all, I would like to thank Dr. A.K. Grover, sir. He's been a mentor for me. And the Vision Eye Center, Dr. Tushar, the entire team for inviting me here. Laptop on it.
So I'll request Dr. Grover also to please come on the dash, sir.
Yeah, I can drop it. No, it's working, I think.
Dr. Rohan is a consultant in Mumbai and in Saharanpur, and is a very young active person in the field of ophthalmology, very active with the Young Ophthalmologists Association. It's a privilege to have him with us.
Thank you so much, sir. So the topic on the floor of the house reads, is femtosecond laser-assisted cataract surgery the future? Well, Leonardo DiCaprio has already given us the answer. It's absolutely not. And even Yao Ming completely agrees with me. Not just that, conventional phaco will stay as the gold standard, and there you go, he's pointing exactly at what the gold standard is going to be. Now, when this topic was given to me, my first, of course, everybody's first instinct is to Google it. I Googled it. What did I write on Google? Conventional phaco versus flax. And all it took Google was 0.45 seconds to tell me this, that in a multi-center case control study, Manning et al. Compared the visual, refractive and adverse outcomes of femtolaser assisted cataract surgery and conventional, and they found that flax did not yield better visual or refractive outcomes than conventional phacoemulsification. So this is what Google said in just 0.45 seconds. Then I thought I'll dig deeper. I'll go in and find some more studies here. So there was this comparison of the refractive predictability and endothelial cell loss, and they again concluded that the endothelial cell loss was significantly lower in flax, but there was no difference in the refractive predictability or the distance visual acuity between the two groups. Then I found this thing of Dr. Uday Devgan, who is known for his cataractcoach.com. He teaches all of us, I mean, we've seen all those videos there. And there again, he has clearly highlighted that there is no real as such advantage when it comes to the visual outcome, which is what we are after when we're doing refractive cataract surgery. Because remember, it is now refractive cataract surgery. Digging in deeper, going into the JCRS, what I found was that, the Academy of Ophthalmology says that flax phaco have similar in safety and efficacy. Along with that, they also concluded that the flax and conventional phacoemulsifications provided excellent visual outcomes, both of them, with few complications. However, they found no evidence to support claims that flax is superior to phacoemulsification, and post-operative complications were any much lower in flax. The other thing that is very important, why it will not become a gold standard, is the cost. This is what everybody sees through their lenses, sees through their glasses that they're wearing. They want to get rid of it, but cost will always be a factor. And whenever, as Indians in our scenario, we hear cost saving, that is exactly how we start looking. The other thing is very important for us to address the elephant in the room, which is the space constraint for the femtosecond laser. Now, urbanization has made sure that we live in smaller and smaller and smaller spaces. We work in smaller and smaller and smaller spaces. So to get that femtosecond machine, you need at least 100 square feet space, if not more, ideally even more than that. So with urbanization, it is going to be difficult for us for it to replace that phacoemulsification in any aspect and to be made the gold standard. Now the thing is that whenever we look at femtosecond, the most important thing that I feel that puts patients away is this. So with my dear friend Tushar, I went to a restaurant. We were offered a 4-course meal over there. Now, what was weird in that restaurant was that they said that, we'll give you one meal here, we'll give you the second meal in the other room, we'll give you the third meal in the third room, and the fourth meal, on your way out, you can just pick it up. So once we heard that, this is what was Tushar's face like. Straight when he heard that. Exactly how our patients would feel when you're doing one procedure in one place, and then, in a lot of institutes, we see this, that the patient is actually waiting for half an hour to 45 minutes between the two. Because if you have 3 to 4 cases, you first do the femto part of it. So the first patient that you did for the femto, that patient is waiting for close to an hour to get the cataract removed. The cricket fever, we know that is here. Today, India absolutely humbled Sri Lanka. So this shot, the reverse sweep, if it comes off, just like Tushar always tries to play it, it comes off, it looks very, very good. But when it does not come off, a situation like this can occur when you don't know where the ball is. So we need to create a sustainable future. And in order to create a sustainable future, the technology that we have already existing, which is giving us great results, and there are multiple studies that are showing that there is no difference visually between the two. So we have to be sustainable about it. Tushar might argue it's two sides of the same coin, but I think we'll have to agree to disagree on this. Thank you.
Thank you, Rohan. So we'll take up Dr. Tushar's few comments after Rohan has spoken against the femtosecond laser. So any comment you want to put forward?
So sir, like I pointed out that, yes, he mentioned that the visual outcomes currently are at the same level. I do not disagree with that, but there are advantages that he pointed out himself, that, the endothelial cell loss is lower with femtosecond laser assisted surgery. And what he did not talk about is the challenging case scenarios, because that's where the true application of femtosecond laser comes into play. When you have a subluxated cataract and you need a capsulotomy which is centered on the bag, or a hard brown cataract, or a white mature cataract. So those are special applications, and I feel that femtosecond laser will be different 15 years from now. It is only improving, it's only in its infancy. So it's wrong to compare a technology that has recently come and is already probably superior or at least equivalent to a technology that has been there for decades.
True. See, there are definitely a lot of advantages of femtosecond laser cataract surgery in terms of, as Rohan has already put, like reduced endothelial cell count, a reduction, and your incision, arcuate incision, you get the correction of the astigmatism, and you get a complete total fragmentation of the nucleus, so before you start the emulsification. But in my point of view, like all these advantages are very, very good advantages of the femtosecond. But what I feel is like if femtosecond laser flax surgery, if it sustains itself without taking the help of the phacoemulsification, so that is the time we have to look forward, I think, in future, if it is possible. Like if it doesn't take the help of the phacoemulsification, then it's fine. But see, actually, because if you are taking finally you're taking the help of the phacoemulsification to complete the surgery, so most of the time what you feel, why to go in for that, you just start phacoemulsification, which takes hardly 2-3 minutes, 4 minutes to complete the surgery, where the flax takes a little longer time, and there are certain drawbacks over the advantages of this surgery, definitely. And I'll take the opinion of Dr. Grover also.
Dr. Bhalla first.
I'll just make few comments. I'm reminded of a saying which said that all men are equal, but some are more equal than others. But here, I think both machine gives equal results. And we base our analysis on the various meta-analysis and the published literature. And as both the debaters have nicely put forward the points in their favor, and there was very interesting studies done by French government by the name of FEMCAT study, then European government did EuroQ and UNETHA study to find out whether all these so-called advantages like endothelial cell loss, effective phaco time translate into better results for the patient. And that's the completely round central rhexis, does it translate into better effective lens position? And they came with the result that the FEMCAT as well, this is not cost effective, the results are almost same, so much so that the governments like UK, Switzerland, and all these governments, even I looked into the literature, Netherlands, Germany, Italy, Austria, Belgium, Slovenia, and Switzerland, they don't advocate it for their national health services. Spain is the only country in the Europe that advocates it for public health. So India, I think, if we see take into account the masses, then if we find that both the surgeries are giving equal results, and rightly pointed out by Dr. Rajendra Prasad, femto is just making some steps of the phaco, of the cataract surgery, that is making incision, arcuate incision, rhexis, and phaco fragmentation. Rest of the job is still done by phaco emulsification. And femto is not reducing the complication rate of phaco. The complication rate, like additional rate complication, is anterior capsular tears, posterior capsular tear, vitreous loss. All these complication rate is same between the two techniques. So I think nicely summed up by one of the great ophthalmologists in America, it has made excellent surgeons, not my words, his words, excellent surgeons average and average surgeons below average. So I think that will sum up, but we'll have the final words from Dr.
Excellent
Kumar.
discussion. I think both sides have been pointed out very well. The literature is quite clear that in terms of visual results as of now, and taking into consideration the cost effectiveness, it may not at present be a major advantage. But look at the question. The question was very cleverly worded. The question was, is femtosecond laser assisted cataract surgery the future, not the present? So the literature as of now may not be relevant to the answer of this question, and the advancement of technology may bring it to a level where this becomes a definite advantage with technological advancement. Maybe it also helps us emulsify the lens at the same time, so that all that you have to do is replace it with a liquid lens or replace it with a different lens which may go through a small incision, or maybe a liquid lens, because you've been able to remove it through a very small incision, as was originally conceptualized by Kelman through his great presentation in 2000, early 2000 in India, in a lecture called Phaco Knit or Phaco Bit or something. Yeah.
Phaco-Knit.
So something like that may come up. So let's see what the future is.
Yeah.
But yes,
So
I think it has been a very balanced debate, and thank you for.
Very nice.
So
bringing
definitely
out
it's going to stay, both the techniques are going to stay for another 15 years, 20 years, I think.
Thank you all the speakers, and
Yeah.
let's have
Thank you very
the
much.
raising of hand. What is the future? Femto or?
Both will have peaceful
Okay, so both are winners.
Uh,
So we'll go on to the oculoplastic debate. May I request Dr. Ruchi to please come and moderate the session on oculoplastics. And we have a very interesting subject coming up. Dr. Ruchi, please. Dr. Ruchi is the professor of ophthalmology, as you all know, at Maulana Azad Medical College and Guru Nanak Eye Center, and has excellent scientific work and clinical work.
Thank you, sir, and for considering me as a part of extended team of Vision Eye Center always. And I think first I would like to invite, it's a very interesting debate. I think all of us are doing, all the plastic surgeons at least are doing LPS resections. And in eponeurotic ptosis, you know, there are multiple techniques of correcting the eponeurotic ptosis, by the transconjunctival route. Let's see what Dr. Rachna and Dr. Ritvija have to say. So first I would like to invite Dr. Rachna Meer, and she is a faculty, you have become additional professor or additional professor at RP Center, and she will be talking about the skin approach of LPS resection.
So at the outset, I'd like to thank Sir and the Vision Eye Center team for having me here. Again, I really enjoyed the debate in the first session, and I was just wondering, have I put it right? My facts are very plain and simple, so may not be as interesting. But I truly believe that the skin approach is best for eponeurotic ptosis. And I have been doing a transconjunctival approach for congenital ptosis, but in eponeurotic ptosis, I'm really not convinced trying a transconjunctival approach.
Dr.
So I'm
Bhalla?
just going to be putting the facts there, and let's see. So eponeurotic ptosis, as we know, results from the levator eponeurosis being dehisced or disinserted from its normal position on tarsus. And this was first described in 1975, and it is the most common type of acquired ptosis. There are a lot of causes for eponeurotic ptosis, but the most common one is involutional. And I've highlighted this because involutional means it's also associated with skin changes and would need, that would also need to be addressed. And essentially the clinical features are very clear. You have a high riding lid crease. There's a lid droop in down gaze, unlike in the congenital ptosis. So yes. So in the down gaze, there's a lid droop, unlike in the congenital ptosis, where you have a lid lag. On palpation, there's a step sign to show that there is a dehiscence of the levator eponeurosis. You may have a visible iris color through the thin skin. And of course, you have a good levator action compared to the degree of ptosis that you have. Now, the aim of correction here, surgical correction in eponeurotic ptosis, is to identify the edge of dehiscence. So the eponeurosis, which was supposed to be inserted here, is dehased and retracted back, and that has to be identified and reinserted onto the tarsus, and that would correct the ptosis. The challenge I believe everybody faces in correcting this is that the outcomes are really variable. Often we find the eponeurotic edge, we reinsert it, but we may not find a correction. In some patients, it may just be overcorrected. So that's a challenge that I always face. And having said that, I would now talk about the advantages that I feel an anterior approach has. So first of all of us are well versed with the anterior approach, unlike the posterior approach, which is a little more difficult and has a longer learning curve, especially for beginners and low volume surgeons. So anterior approach is definitely easier and well tested. Now, blepharoplasty, like I said, skin blepharoplasty is indicated in many cases of involutional ptosis, and so that can be done through the same incision. If you're doing a transconjunctival approach, of course, there will have to be two incisions, both through the posterior lamella and the anterior lamella. Now, most of these patients would have some ocular surface problem owing to aging and dry eyes. So doing a transconjunctival approach means that you are inducing a conjunctival inflammation and scarring, which of course can add and exacerbate the ocular surface irritation. So that is another concern in these patients. And the most important thing that I think the anterior approach allows you to do is it permits you to have a look at what is actually happening. So you may be able to see the eponeurotic edge, and when you kind of reinsert it and look on table for the correction, and you don't find it, then you know that this is not really the edge that you need to insert, and you may do a deeper dissection to find the same and reinsert it on the tarsus. Sometimes you may have an intra-op surprise. So many of the ptosis, occasionally some of the ptosis would look like involutional ptosis, but when you open up and you do not find a dehiscence, then you have to change your plan, and you may go in for a plication or a resection. So somewhere something has lagged in your clinical evaluation, and that can be adjusted intraoperatively. Thirdly, suture adjustment is easier in the anterior approach. In posterior approach, usually most of the surgeons do a single suture application, which can give you contour deformities, and you may have to redo it, and this is really difficult when you are doing it from the posterior side. Anteriorly, you could put 3 sutures and you can get a good contour. So that is another add-on. So contour anomalies, yes, and of course if you have to do a resurgery, then of course anterior approach is definitely easier than doing it through a posterior transconjunctival route. So this is just a short video to show the anterior approach. Maybe we can mute the music if I think it's a little bit loud. So the initial steps are same as that for LPS resection, the skin route. We do place those three marks for the 3 sutures that we are going to pass through the tarsus. We mark a skin crease which has to be symmetric with the other eyelid. We infiltrate with the block. I usually do not give a frontal block. It helps you have a better assessment of the lift intraoperatively. We pass the stay suture through the central cardinal mark that we'll be using to pass the central suture through the tarsus. An incision is made with a 15 number blade, and this is where I want to hold it. So this is after you have dissected off the orbicularis, and what you see behind is not the septum. Normally when we separate, what we see is septum, which is pale and white, but what you see here are either the residual fibers of the levator or the Muller's muscle. And where is the fat pad? You don't see the fat pad. So when you lift up the upper lip of the wound, this is where the fat pad is. So what happens is that when there is a disinsertion or dehiscence, there is a retraction of this aponeurosis along with the septum, and the fat rolls back into the orbit. So what you have to do is to look for this fat pad and then just explore underneath it in this plane to find the rolled up aponeurosis. And this is, you find this edge and then you dissect it off, and that's how the septum should look, septum and aponeurosis. And this is then reinserted onto the anterior surface of the tarsus. And like I said, I generally use 3 sutures. This is the central one. And once sutured back, you can see the lift is coming, and you know that you've done the right thing, and this is what has to be resutured back. So all the 3 sutures have now been passed. And once you close it, there you can see the contour. So you can control the contour, and then of course you close the skin incision, taking bites through the LPS, and that's the lift on the first post-op day. So at the conclusion, I would say yes, skin approach is the best. It allows you to identify the dehiscence clearly. It addresses any associated skin changes. And in absence of a clear dehiscence, you can change your plan and go ahead with a plication or a resection depending on what you find intraoperatively. Thank you.
Thank you, Dr. Rachna. It was very well, all the points were very well discussed. And first, I think I'll invite Dr. Ritvija, and then we'll have a discussion.
Thank you.
So a very good evening to everyone who came out to spend some time with us today. And of course, it's the attractive power of Dr. Grover that brings you all. But I'm glad that we get to meet everyone. And I'll just So initially I was thinking of, going for a hardcore debate, but it so happens that Dr. Rachna was my examiner for FICO, so I don't think I can really fight with her. So I'll also be just putting the facts across. So of course, as Dr. Rachna mentioned, she does do the posterior approach for congenital ptosis. And it's not only for congenital ptosis that you need to do the posterior approach. You can do it even for aponeurotic ptosis. It's important that we go by the measurements and of course choose cases well. That is based on their pre-existing lid contour and if they have dermatochalasis or not, and where the lid fold is present, of course. So for the posterior approaches, we have of course muellerectomy, and you can do a levator resection from the posterior aspect, that is the white line advancement procedure. And we reserve these procedures mainly for mild ptosis. However, you can get some more correction with the white line procedure as well. So this used to be the classical Fasanella servat surgery. However, this is much more simple now after the study from AIMS, and this is how the Fasanella servat surgery is done. And you can get good results with Fasanella servat. But what we are discussing is involutional ptosis. So of course, I would like to agree with Dr. Rachna also, because levator resection is skin approach is our bread and butter. But what happens in this case is, if you choose the case well, you can have a much shorter operating time with a good MRD1 at the end of surgery. And this has to be done, that is Mueller muscle conjunctival resection, only after a good response to phenylephrine has been obtained, which means you know your Mueller's is going to work well. And it can also be done in patients who have enucleated eyes such as these as well. So I'll just quickly go ahead and show you how easy the procedure is. You go ahead and put the traction sutures. So this is just a sped up video. I have not edited out any parts in between. And you just mark the entry and exit points. You can leave the suture internally as well. He has some amount of allergic conjunctivitis because he has a custom prosthesis inside. You go ahead and put a Putermans clamp. And then once you get the clamp in place, without taking the tarsus, you pass your sutures. About 3 or 4 throws is good enough. And what I like to do is exteriorize the suture at the end and then tie it over the skin. And you can just do a metal on metal contact and excise and then tighten your sutures. So that was pretty simple, and you get very satisfying results with this. And it works really well, especially for people who've used contact lens over several years and have developed mild ptosis after that. It works well for them too. Now, what happens mainly in this surgery is the plication of the posterior lamella rather than resection of the Mueller muscle. Now, the complications I just want to mention, I'm not going against my topic, but I just want to mention that you need to choose the case well. So we need to reiterate the fact that if your eyelid fold is not present from before, you're not going to get an eyelid fold again after surgery. So these are some of the issues. So if you choose the case well, you can do it well. Dr. Rachna did mention this about where it is contraindicated. But 2 things I would like to mention from ma'am's presentation is, one, that it's not that the contour cannot be as good in this. So contour is actually a little better in Mueller muscle conjunctival resection because it's far more predictable. But the other thing is that you can sort of differentially excise. It's not that you have to excise a fixed amount or in a fixed line. You can excise a little more towards the nasal side or a little more towards the lateral side, depending on the other eye contour. The other thing is that you mentioned that when you do a levator resection through the skin approach, you can do a blepharoplasty as well. Well, several cosmetic surgeons across the world are now preferring to sort of do the internal approach, muellerectomy, because it gives a good predictable outcome, 2 mm correction, and do a mini blepharoplasty. That is, then go ahead and remove the skin. So that is where I would say that you don't get any overcorrection if you choose the case well, you don't get contour abnormalities, and it has a short learning curve, and it's quite reliable. Now, the Posterior white line approach, I think Dr. Ruchi will also talk about this a little bit in our discussion. This is where you go ahead and find the levator, the end of the levator, that is the aponeurosis, from a posterior approach. So after reflecting the conjunctiva molars, you go and find that. And that is what is used to sort of go and suture it back to the tarsus from an internal approach. And this is preferred, of course, in Asians who don't want that scar over the external surface, especially if they're not undergoing a blepharoplasty. And you can, this is the same study, you can get good results for mild, moderate, as well as severe ptosis. So this is the advantage of this. It's not only for mild ptosis that you can adopt a posterior approach. So thank you, and we'll discuss.
Yeah, thank you, Rituja. And I think wonderfully all the points have been covered by both the speakers. Just to add a little, it's basically when you're talking about the aponeurotic ptosis and senile ptosis per se, it's the changes due to aging that are occurring which make the conjunctival approach a little better. This is what the studies have also shown. And because of the thinning of the tarsus and the posterior displacement of the levator in senile ptosis, so when you're doing an anterior approach, you in your own video you show you were really looking for the retracting muscle. But when you're doing a posterior approach, you're actually bang on top of the muscles. So this is one advantage. The other thing that has been discussed in literature is that because of the thinning of the tarsus, especially medially, when you're passing the sutures from the anterior approach, you're passing partial thickness sutures. Whereas when you're doing a posterior approach, they are full thickness sutures. So the chances of undercorrection on the medial end are less when you're doing a posterior approach. Now again, I'm not on Rituja's side, that I'm speaking on the conjunctival side, because all of us are very well conversant with the skin approach. And I would agree that most of these patients are going to need some bit of blepharoplasty. So definitely when you're anyway going to make an incision as well as finish it off. And the other thing that is there is that many of the young patients, when you take it, they would have, vernal catarrh, like Rituja was showing, their conjunctiva would not be healthy. So why touch a unhealthy conjunctiva? So I guess both the approaches have their own advantages and disadvantages. And any comments from Rachna or Rituja, and of course the final authorities, sir.
I think again the point is well taken that Muller's resection does really work well, and but posterior white line advancement again I am not so sure, because full thickness sutures again it would induce from whatever studies I saw there are cases which need a second surgery, and there are cases which have problems because of those full thickness sutures that are put again. So like I said, I'm not really convinced about the posterior approach, especially in the severe senile ptosis, but I think I'll hand over to Rituja and Sir for their.
Yeah, so I think this is probably the first time at the end of a debate that we would agree to agree, because each thing has its own advantages and disadvantages, and we need to sort of do what's best for the patient. So I'm sure that if I had a patient who required anterior approach levator resection, I would do that. If they required posterior approach, that is somebody who has a very mild ptosis, I would probably go for the Mueller muscle. So it's just indication based is what I feel.
This was a very Pika debate, too much respect for each other's point of view. So essentially, there are of course those indications like congenital where I would almost always do skin approach. But for aponeurotic ptosis, increasingly I've found that the predictability of the conjunctival approach is fabulous. And somehow if the phenylephrine test is positive, then they do so beautifully that you wonder why you were doing skin approach with all those thoughts about possible undercorrection, overcorrection, requiring readjustment in the aponeurotic age-related cases. So for that particular indication, I favor the conjunctival approach since I've shifted to it over the last couple of years. And the white line approach I have never used, but it is particularly favored, as she said, by the so-called Asian or Mongolian eyelids, where people do not want to go from this skin approach. But then again, predictability would be as doubtful as you would have with the skin approach. So
I think
both approaches.
epinotic is one thing, sir, we can never be sure. We may have to go back and readjust things. So,
So conjunctival approach somehow, I don't know, it works like magic. So it goes, if phenylephrine works, it goes exactly where it wants, where you want it to. Why, how, we don't know. But it works very beautifully. For that particular indication, yes, conjunctival approach is my choice. So thank you, Ruchi, for a wonderful discussion. The next discussion is on vitreoretina surgery. I'll request Dr. Apoor Grover, Senior Consultant at Vision Eye Center, for moderating the session. He's an excellent surgeon, clinician, and very humane to his patients. So I think we look forward to a wonderful debate from him. And Dr. Rohini Grover, who's a consultant at a number of institutions in North and West Delhi, Healing Touch, Caring Touch, Ramakrishna Mission, and Dr. Anshu Arora, who's at Vision First Eye Center, Noida, and a visiting consultant to Vision Eye Center as well, will be the.
Thank you. Now, proliferative diabetic retinopathy is one of the more commonest scenarios that we see in our clinic, and as you know, PRP has been the gold standard for proliferative diabetic retinopathy. However, the recent studies, drcr.net studies, Protocol S, Protocol AB, have also shown excellent results with anti-VEGF injections in PDR. So in this common clinical scenario, how to tackle it, it remains a matter of debate. And our first speaker, Dr. Rohini, she's an experienced surgeon practicing for the past 9 years. She's been training vitreoretina consultant, vitreoretina fellows for the past 3 years. Yeah, she'll be speaking on anti-VEGF injections, how she feels they offer the best result.
Thank you, Dr. Apoor, for kind words, and thank you, Dr. Grover, for inviting.
So Dr. Rajendra Prasad and Dr. Balla here, are they here? Can request them to join us here. And Dr. May I request Dr. Rohit Saxena to please join us here.
So recent onset vitreous hemorrhage. First of all, we have to see the topic today is recent onset vitreous hemorrhage in proliferative diabetic retinopathy. Whether anti-VEGF intravitreal injection or vitrectomy surgery offers the best result. So I'll be speaking in favor of anti-VEGF intravitreal injections. First of all, before going to the study part, we have to first realize that we are in India and diabetes is epidemic here, and it is increasing, and our load of diabetic patient is increasing day by day. The major complication of proliferative diabetic retinopathy is vitreous hemorrhage, and as Apoor has told that Protocol S has been done, and that result showed that proliferative diabetic retinopathy patients in next 5 years, 50% of them experience vitreous hemorrhage. So anti-VEGF act on angiogenesis. So we are actually hitting the main pathogenesis of vitreous hemorrhage. In 1970s, we had only one option, vitrectomy, or as Dr. Apoor mentioned, we started with PRP. But with the advent of anti-VEGF, the paradigm shift is towards intravitreal injection. And we have a lot of injections available in anti-VEGF therapy. So 40% of PDR patients do not respond to PRP treatment, and PRP does not increase the visual acuity. Again, we have vitreous surgeries, vitrectomy, which is very invasive. So VEGF has anti-VEGF therapies provide a strong rationale. So there is a Protocol AB, a head-to-head trial on comparing aflibercept, which is an anti-VEGF, and vitrectomy. So the study compared 1:1 ratio, and the primary outcome was to study the visual outcome, and also at the end of 6 months, how many patients of vitrectomy group were offered aflibercept and how many aflibercept group patients were offered vitrectomy. So this was found that 33% of vitrectomy group patients underwent aflibercept injection, and aflibercept same for the other group. So there was no difference, 1:3 ratio. And aflibercept injections were definitely more in this study in the aflibercept group, that is 8.9 on an average. Initial 1 month vitrectomy does better, but after 4 weeks, the study was conducted till 24 weeks, that is 6 months, and till 2 years. And it was found that both the groups had same visual acuity and their results were comparable. So the primary visual outcome was studied as letter score. So the letter score was also the same. Mean visual acuity in both the groups was same. There was slightly better letter gain in aflibercept group. And also in aflibercept group, DME was treated better. So this was a clinically significant that those who are having pre-existing diabetic macular edema, which is actually masked in the presence of vitreous hemorrhage, and if we are giving anti-VEGF, we are also targeting diabetic macular edema, which surgery is not doing it. So ocular safety of both the groups was same, and as previously mentioned that there is more tractional retinal detachment with anti-VEGF, this is also not in support, because the recent studies have shown that there is no increase in tractional retinal detachment after giving anti-VEGF. It is the disease process that TRD will happen in any group and in the same percentage. So this was the summary, but the points to ponder here are that in the presence of vitreous hemorrhage, actually the DME is getting masked, macular ischemia is getting masked. We know anti-VEGF also treats macular ischemia, it increases the perfusion. In vitrectomy group, they also offered anti-VEGF later on, but the clearance of anti-VEGF because of in the vitrectomized eye, because of diffusion is more, so it is less effective. And a country like India, where we have many patients who have uncontrolled diabetes, they are poor, they don't have Mediclaim services, I think first choice we should offer them anti-VEGF therapy. This patient was offered a surgery in the first go, and the patient came to us and didn't get treated by previous surgeon. So this patient was later on given 2 injections of intravitreal, and then laser was conducted. Again, a pre-retinal hemorrhage also responded well to anti-VEGF therapy. Patient having diabetes are on dialysis, on coagulant therapy, having foot infection or DME prior, do well with anti-VEGF therapy. So in the summary, there is a disease burden. We have economical options available. Anti-VEGF is an office procedure. If we tell the patient same day that go for an injection, your vision can be saved, they will straight away go to the OT same day. But you offer them surgery, they will never go for surgery in the same day. There is a repeatability. Some medical insurance always give less amount, so anti-VEGF can be easily covered, and concomitant diabetic macular edema is treated with the anti-VEGF. In vitrectomy group, sometimes the patient is systemically unfit, there are psychological factor, cost of surgery, and the surgery cannot never be planned on the same day. There is also a recurrent vitreous hemorrhage issue with vitrectomy. After any anti-VEGF injection, if the patients get vitreous hemorrhage, they are still repeated with anti-VEGF, or the surgery option is still open for them. But after doing vitrectomy, if there is a vitreous hemorrhage, again telling the patient you need a vitreous lavage, that is very irritating for the patient, and we sometimes these patients go lost to follow-up. So again, cataract, iatrogenic touch and loss, use of tamponade, vitrectomy has a higher rate, 7% higher rate of having cataract. So still there is no right and wrong, and we have to do a customized and tailor-made approach to all our patients, and it should be an individual approach, because we know that vitrectomy acts a little faster, and that is the only advantage. Thank you.
Thank you, Dr. Rohini. You've summarized the literature very well. I just wanted to ask you if in your practical setting, would you still go for a PRP, right, when you've done the anti-VEGF?
Yes, after giving anti-VEGF.
How soon do you start the laser after giving the anti-VEGF?
See, with LIO, we can start laser therapy early, but if we have a slit lamp laser available, then it takes 1 to 2 weeks. Otherwise, as early as 3 days, we can start superior laser at least after giving anti-VEGF.
True. So as soon as the vitreous hemorrhage starts
clearing up. Normally it takes 4 weeks to clear, 1 month.
Also, I think case selection in this case would be important. Any traction which is threatening the macula would obviously we need to tackle.
The topic is on recent vitreous
Yes,
hemorrhage.
yes.
So we are assuming that
There is no traction. Yeah, so we should just know that case selection is important. Thanks.
Yes, thank you.
Excellently, you put
Whatever wrong she might have said, I may be forgiven. She was a student at Sir Gangaram Hospital, so I take the fault.
Thank you. Dr. Anshu, our second speaker, is an experienced vitreoretina surgeon based in Noida. His help is sought by VR surgeons all across Delhi and NCR for complex surgeries. He's trained at Shankar Netralaya. He's been a high achiever. He's performed more than 3,000 vitreoretinal surgeries. He'll be speaking in favor of early vitrectomy in recent onset vitreous hemorrhage.
Thank you, Apurv. Apurv is not only a colleague, he's a very good friend of mine, and Dr. A.K. Grover has been very kind always, and he's been a stepping stone for my career also. So I thank them both to invite me for this presentation. So let me start by saying that a recent onset vitreous hemorrhage should really not be misunderstood as a recent onset diabetic retinopathy. Okay, so what we are dealing with is a complication, a stage where there is a vision threatening situation. So my disclaimers are I don't have any financial interest, I don't have any deficiency of vitreoretinal surgery, so that I am inclined towards more VR surgeries, and like everybody else, I love anti-VEGF too. So basic plan with PDR, as we all know, is laser photocoagulation, and that is the gold standard of treating any patient with PDR. And it is must in combination of either we do anti-VEGF or we do a vitrectomy. So, but when we look at the various studies like DRCR net, which I believe most of the retina person know about, but to the knowledge of others, DRCR net is a group of practices which organizes various studies related to diabetes, and their outcome since 2003 has been guiding light to all the retinal surgeons all over the world. So the protocol S, which Dr. Rohini also talked about, shows that almost 19% of people who were in protocol S after 5 years developed vitreous hemorrhage, which required vitrectomy, and even in group of anti-VEGF, there were around 11% patients. But that is not the reason why we should incline ourselves towards vitrectomy. The deciding factors should be an appropriate case selection, safety in terms of long-term treatment, efficacy in terms of good outcome, and durability in terms of lesser risk of recurrences. The other factors which make our decision making easier is to look at the economic burden and the compliance issues. So what happens when there is vitreous hemorrhage? When there is vitreous hemorrhage, if you leave it like that, if it doesn't bleed, it clears by 1% a day, and you might get a clear vitreous in about a month or so. So, there was a study by DRCR which is called as Protocol N, in which they compared whether to inject anti-VEGF with saline. And surprisingly, the results were very discouraging towards anti-VEGF. They said the anti-VEGF does help in clearing of vitreous hemorrhage, but it said it doesn't help in regression of the bleed as such. It does stop the new bleeders, but it doesn't cause regression of the bleed. So there was another, with vitrectomy, the recovery was much faster. So there was a landmark study way back in 1985, you must have all read about it in your curriculum, that was called as diabetic retinopathy vitrectomy study, in which it was clearly stated that the patients who have good vision, they are the patients who are in early vitrectomy group. They did very well as compared to delayed vitrectomy group, especially patients who were type 1 diabetic, and the other fact which DRVS stated that the patients which had poorer visual acuity on presentation, they were the ones, though they had again had better visual outcome with vitrectomy, but since they already had a baseline poor vision, there was no advantage seen in early vitrectomy in type 2 diabetics. So what do I mean by case selection? Do I operate on any vitreous hemorrhage? No. If there is an obscurity of the fundus, if you are not able to do a vitrectomy, not able to do your PRP lasers, then that is the case when you should look for doing an early vitrectomy. If you see a fibrous proliferation lying at the back posterior pole, which can lead to early TRD, then you look for doing an early vitrectomy. And of course, if the macula is involved with the tractional retinal detachment, you have to go for an early vitrectomy. Why is it so? It is so because there is a major compliance issue in diabetic patients all over the world. The larger studies like the one shown here in American Journal of Ophthalmology says that almost around 50% of patients are lost to follow-up. So what does it mean? There's loss to follow-up patients, which are going to be very dangerous if we start treating them on anti-VEGF alone. So what happens when we leave them on anti-VEGF alone and they get lost? When they get lost, they come back with a more aggressive disease. They come back with a tractional retinal detachment. They come back with an aggressive neovascularization. So looking at a long-term solution to the problem, vitrectomy does curtail these issues. So I'll skip this. So what I will come to the most important study which actually compared these two topics head to head, which was the protocol AB. And I will just summarize the simple results, simplified as Dr. Rohini has also mentioned, that almost 1/3 of either group, be it vitrectomy group or be it anti-VEGF group, they required the assistance of the other group. Like 1/3 of the vitrectomy group went for anti-VEGF because of either DME or a recurrence of hemorrhage, and 1/3 of aflibercept group went to a vitrectomy scenario. So, but at the same time, as we look at the cataract and the cataract surgery percentage, it was fairly the same. In fact, it was tad higher in aflibercept group. When we look at the visual acuity changes, very early recovery, as Dr. Rohini has said, week 4, there was 11 letter gain, and week 12, it was around 5 letters gain in case of PPV. But when we look at a confidence level interval result, there was a significant difference, about 10 letters, in case of pars plana vitrectomy. So the vitrectomy group, they have a better visual acuity results. They had faster recovery. They had less recurrences of hemorrhage. And the anti-VEGF group, for those who are not opting for surgery or those who come back for recurrent vitreous hemorrhage. So what is other main concern with anti-VEGF is the systemic safety concerns with anti-VEGF. A red flag is often raised with concern of morbidity and mortality with long-term use of anti-VEGF injections. Once we decide on not operating on these patients, and there are chances that the agents will be used more frequently, there are about 1 to 3% chances of mortality. The second study which indicates more risk of all mortality in patients, overall mortality in these patients who receive frequent anti-VEGF. Coming to the last point is the cost-benefit analysis. Let's look at the cost-benefit based on the study, which is protocol AB. When we look at the average injections done in 2 years' time, which was 9 injections of aflibercept, even if we considered the benefit offered by the company which manufactures aflibercept, it costs around 2,70,000 to the patients. Considering biosimilar, if we go down to biosimilar, which is not an off-label drug like Avastin, it would come to around 18,000 to 2 lakh rupees. About 30% will still have additional burden of surgery. So if we look at surgery, we can do with half of that amount in the first go, and which will benefit 70% of these patients. And of the 30% patients who require anti-VEGF, you still have that backup money which you have saved with vitrectomy. So last, what are the ideal cases I usually consider for early vitrectomy is the patients who have coexisting macular TRD, which has been teaching for all of us for a long time, young type 1 diabetic, as Dr. DRVS has said, uniocular diabetic patients with only seeing eye, where you require an early visual rehabilitation. And then there is comorbidity of stroke or MI in recent past, where you have a guarded use of anti-VEGF, when you have a florid neovascularization at the disc elsewhere. The other important point which our investigations reveal is, if you have a posterior vitreous detachment, you can still wait, but if the vitreous is acting as a scaffold to your neovascularization, then it's better to go ahead and separate your vitreous and do a reasonably good job of saving that eye. A thick posterior highlight, even when there is no tractional retinal detachment, is also an indication for surgery. So the take-home message is good metabolic control is the paramount importance. Patient education is very important so that you get less of loss to follow-up patients. Early vitrectomy patients in high-risk PDR where PRP is not possible when the fundus is obscured. Younger than 50 years patient with type 1 diabetics with limited or no posterior vitreous detachment and vitreous hemorrhage are the most beneficial group of the patients. The comorbidities such as hypertension, renal impairment, and hyperlipidemia worsen faster and need closer follow-up. And considering early rehabilitation, cost implications, and longer stability, early PPV in these patients should be considered. Thank you.
Thank you, sir. Very well explained. Just a couple of questions. Now, in your personal experience, do you find it more difficult to convince the patient for a surgery vis-a-vis an anti-VEGF injection? Sometimes I feel that they agree on an injection much more easily, and I think we also would supplement an injection with PRP as well. So hopefully that might bring down the need for future repeated injections.
Yes. So basically, it is definitely easier for you to convince the patient on going for a lesser invasive, I should say, procedure. But then, if you are confident enough that you are going to give a good result to the patient in an early diabetic vitrectomy, and you know that in a later part of the disease, when you are facing tractional detachment and when you are facing, a dense fibrovascular polyp, which is going to give you a later worse result, then it is easier to educate patient that doing it earlier is a better choice. And believe me, if you go in a very confident manner and explain to the patient the normal, natural history of the disease, then it's easier to convince them for surgery.
Thank you. Yeah. So as discussed, case selection here is important when we are selecting and the treatment has to be individualized. Also, do you face instances of rebleed even after a vitrectomy? How do you prevent that? And how do you tackle it if a rebleed occurs after a vitrectomy? How do you convince the patient to go for a surgery again, or will you try an anti-VEGF in that case?
Yeah, see, normally when we do vitrectomy in cases where we have sutureless vitrectomies, this is the era of sutureless vitrectomies. So in sutureless vitrectomies, the major issue what we face is hypotony post-surgery, and which does lead to larger number of patients coming back with small amount of rebleed. So to reduce that, first you have to make sure that you have cauterized all bleeders. And towards the end of surgery, what I usually do is I reduce my IOP, my intraocular pressure levels, to around 10 millimeter of mercury, and then I look inside and see whether I still have any active bleeders. So when you're operating on a higher pressure level, sometimes the bleeders doesn't activate. But as soon as you bring them to a real post-operative situation like a hypotonous situation, then if you find them bleeding, then you have to cauterize them, or you have to stabilize that part of the bleed. Post-operative, reducing post-operative hypotony, I would still prefer sometimes to put sutures on my When I'm operating, sometimes I put sutures when I see even a slightest doubt of leak in my, sclerotomy. So that helps a lot. But even if patient comes back with little hemorrhage, usually that kind of hemorrhage usually settles down in about 2 weeks' time. So that is not of a major concern to me.
Sometimes I've seen a rebleed happening a month or 2 months, sometimes even 3 to 4 months after a vitrectomy, which may sometimes doesn't resolve. In that case, what will be a line of management?
Yes. So basically the resolution of hemorrhage in a vitrectomized eye, as we all know, is faster, but there are certain patients, I would consider them, say, around 2% of my practice, that they do come back with a non-resolving rebleed. And for that, I usually prefer to give an anti-VEGF first and then wait for another few days. If it doesn't clear, I go ahead with doing a vitreous lavage.
Thank you. So I think to summarize, both injections and the vitrectomy surgery both have a role, augmented by PRP, of course, where required.
Thank you for a wonderful discussion. I don't think audience will take a view on this. Any views on one or the other? Hands for Dr. Anshu or hands for Dr. Rohini? Hands for Dr. Anshu?
It's a non-competitive debate.
I don't know anything about vitreoretina surgery to say anything, but what I can say is Dr. Anshu is an avid bird watcher, a nature lover, and a nature activist, and so is the moderator. Both of them are bird watchers.
So you have very rightly said that both the things have role. So do you combine both the treatment together? Like you said, you do straight go for the vitrectomy, and why not to give injection and then do vitrectomy?
Yes.
Or do vitrectomy and then give injection?
So basically that is what we were following for quite some years, like last maybe 5 or 6 years, maybe 10 years, a decade now, that we give an anti-VEGF prior to a vitreous surgery. That doesn't only reduce the number of recurrences, it does ease up our surgeries a lot, because on-table bleeding is much lesser when your patient has already received anti-VEGF. So anti-VEGF does act as a boon for us when we are operating cases of diabetic retinopathy. But what bothers me over the years, what I've learned, the most tough operations during vitrectomy is the one which has apart from bleed, if there are changes in diabetic retinopathy. Like if you have a prolif, if you have a tractional detachment, if you have a combined detachment, those are the cases which really end up with very bad visual results. And we've been, treating patients quite late. Like we should be taking up these cases when they are in early stage, so that we remove the, the scaffold on which the disease grows. That is the most important, the vitreous which goes.
Thank you very much. Thank you, Dr. Apur and Dr. Anshu and Dr. Rohini. Now request Dr. Rohit to moderate this squint session. Professor Rohit Saxena is the incoming president of the Delhi Ophthalmic Society. He is a professor of squint and neuro-ophthalmology and amblyopia at the Dr. Rajendra Prasad Center, All India Institute of Medical Sciences, and a well-known surgeon all over the country.
Thank you, Dr. Grover, for the opportunity and the chance to interact with a wonderful audience. So we'll be moving on to strabismus now. I have two extremely capable, young, dynamic, and able surgeons. Looking at the environment and the way things have gone, I was hoping that there would be some good cat fights, but lagta nahi hai. We have Anu, who has joined back at GNEC as a faculty, and being trained in GNEC, I'm sure she would have good claws, but up against her is Dr. Smita, who is very placid, calm whenever I've seen her, although she does some excellent surgeries and the cases sometimes when I've had a chance to discuss with her. So both are extremely capable. We'll I think start with the topic basic intermittent divergent squint. Surgery would be symmetric or asymmetric. So we start with Dr. Anu, who will be speaking for symmetric surgery is the gold standard.
Good evening, everyone. So exotropias are one of the most commonly encountered squints in our OPDs, and intermittent exotropias, that is IDS, encounters the major chunk of these exotropias. Now, whenever we have such patients, we are always in a dilemma which surgery to go for. whether to go in for a bilateral recession of LR or to go in for a unilateral recess-resect procedure. I'll be talking about symmetric surgeries. We all know the indications to treat such patients when they have a poor control or a larger angle of deviation, or they break easily or recover poorly, or are developing asthenopic symptoms of poor quality of life or diplopia. And treatment options are varied from options like over-minus lenses or prisms, and some surgeons have even tried Botox with variable results, but the gold standard remains surgical management. Now, when talking about surgery, we are always in a loop to go in for bilateral LR recessions or R&R procedures. Now, Dr. Burton Kushner, who's one of the pioneers in exotropias, himself projects that R&R is a better surgery. He's had studies on RCTs with one-year follow-ups as early as 1998, mentioning that R&Rs has a success rate of 82%, vis-a-vis bilateral recessions, which have a success rate of only 52%. Other one-year studies also have similar results. However, that does not discourage us from doing a bilateral symmetrical surgery. Surgeries, just because a few studies have projected R&R to have a better outcome, does not make bilateral recessions outdated. Studies with a longer follow-up period of up to 2.8 years by Yuskil in 1998 have projected a gross difference, 57% success rate in recession symmetrical surgeries versus 50% in R&R. Another study recently published by the Korean group Choi with the long-term follow-up of up to 4 years also projects a better R&R, a better result in bilateral recessions of up to 58% vis-a-vis 27% in the R&R group. The recently published PEDIG study, which is one of the very important studies published in 2019, it was an RCT with almost 200 children in the age group of 3 to 11 years, studied these bilateral recessions versus unilateral R&R and compared these approaches and found that there was no significant difference in the results and outcomes. Also, the cumulative probability of a suboptimal outcome by 3 years was not statistically significant between the two groups. However, they encountered that the immediate post-op diplopia was significantly higher in the R&R group, up to 38% compared to 18% in the bilateral recessions. Now, even though this recovered over a period of time, the diplopia may be troublesome to patients. So better results do mean that there may be some amount of overcorrection in the immediate post-op period, and the patient may be troubled by that. Now, to counter these poorer results in some studies of the bilateral recession groups, some researchers came up with the augmented bilateral recessions to improve their outcomes, wherein the LR recessions are augmented by 1.5 to 2.5 mm of the standard Parkes dosage in each muscle, depending upon the angle of deviation. This was a study published by the Lee group from Korea in augmented bilateral recessions. However, they've compared these augmented recessions with the standard recessions and not R&R. They found that the results of these augmented recessions were significantly better, that is 68.2%, compared to standard recessions, without any increased rate of overcorrection. They've even tried augmented recessions in small angle IDS, wherein we needed to tackle only one muscle, and found that the surgical dose of 9 mm was preferable to 8 mm without any difference in the rate of recurrence, with a significant difference in the rate of recurrence. Now, talking about a few case scenarios of the basic type of IDS, this was a 28-year-old female who had an IDS of poor control, up to 55 prism diopters on distance after 1 hour of occlusion therapy, and underwent a bilateral recession of 9 mm and is doing ortho at 6 months follow-up. Another female, 24-year-old, with IDS and fair control, with up to 50 prism diopters of deviation on distance as well as near with 1 hour post-patch, underwent a bilateral recession of 8.5 mm and is doing good at 3 months follow-up. This was another 22-year-old female who had a good control but would break easily, with the prism diopters of 40 PDs and underwent 7 mm recession bilaterally and is doing good at 6 months follow-up. This was an 18-year-old female who apparently seems ortho here. She had an IDS with a very good control. However, she would break very frequently and was having psychosocial implications of the same. She had a 30 PD of exo and underwent a surgery of 6 mm bilateral recession and is doing fine. This is the post-op day 1 picture, but she's doing fine at the last 2-month follow-up period. Even my colleagues who are in other centers are doing bilateral recessions and swear by this. The other advantage is that bilateral recession tackles is the lateral incompetence as the horizontal incompetence and the correction of DVD in the same sitting, along with palpable symmetry. Now we know that exotropias, especially IDS, is a comitant squint, but researchers have found some amount of incompetence even in these. Moore described lateral gaze incompetence, and it has been studied by other researchers up to the tune of 41%. Now, a unilateral RNR may worsen this lateral gaze incompetence, and hence bilateral recessions are the way to go when you have such incompetences. Researchers have also studied incompetence and eye dominance in intermittent exotropias, even though we talk about similar visions and competency there. They found out that it was up to the tune of more than 40%, 16 out of 37 subjects having incompetence and eye dominance was seen in one of these patients. And they found that a difference in refractive error may be the cause, with a higher hyperopic error having a reduced exotropic angle. And so bilateral recessions give you the option of performing an asymmetrical surgery to obtain optimal results in such case. We also encounter DVD very frequently in intermittent exotropias, especially when they have the onset at a younger age. So an bilateral recession gives you the advantage of opening up both the eyes, tackling both the IOs at the same time, so that you have symmetrical results, and single incisions can be done. But I would end by saying that ultimately it is your choice, and more so, we learn from our mentors and we take up their choices and we take up their teaching skills. And then it is also depending upon the longitudinal results of your own surgical outcomes over a period of time with the different techniques. So ultimately, in view of patient's betterment, you have to do what's working best in your own hands instead of going in for one other than the other, because there's no unanimous decision of which is better or which is not. Thank you.
Thank you, Anu. You seem to have put the blame on your mentor for all the mistakes that you made. Thank you, Anu. We'll have Smita now talking on asymmetric surgeries give good results too.
So, good evening, everyone. I'm glad that all of you are here today for us. Anu has given us a detailed talk on how LR recession bilaterally should be done, but I'll be explaining how the asymmetric surgery gives good results too. So we are only discussing this because intermittent exotropia is the most common type of exotropia which is seen among Asians, and it is a debatable topic because the type of surgery that should be done is still not what we should be doing. And exotropia, usually what happens is that after surgery an exotropic drift occurs after a few years. So the biggest advantage is that if we are doing surgery in an adult, then we can perform it under local anesthesia, either by giving a peribulbar block or a subtenens block, and we can avoid the risks of general anesthesia, and also the duration of the surgery becomes less. So we don't have to keep the eyes patched, and the patient can be mobile for the day. Also, in our practice, what we see is that by the time the patients come to us, suppression has already started in one eye, and there is a fixation preference. So in such patients, it is important to do a unilateral recessive sec procedure, as we don't need to touch the non-dominant eye. Also, by strengthening the medial rectus, the convergence improves, and this gives good long-term results. In small angle exotropia, we do not need to touch the dominant eye because we have to do a surgery in the non-dominant eye. So my opponent has said that the disadvantage is that lateral incompetence occurs, but even on the first post-op day we see that even because there is edema, we do not see any lateral incompetence, and if we are using the standard dosage tables, that is 8 millimeters for lateral rectus and 5 millimeters for medial rectus, we do not get a lateral incompetence. Also, we do not see any significant palpebral fissure width changes if we are using the standard tables. So what does the literature say? This was a study published in 2013 in which there was a mean follow-up of about 1.5 years, and the RNR group had a higher success rate, undercorrection was much lower, and there was no difference in overcorrection between the two groups. Another study published in 2018 included 7 studies in which 5 systemic reviews were done, and the unilateral RNR was shown to have a greater surgical success, and there was a decreased rate of undercorrection as well as recurrence. And finally, the most recent study which has been published was by the Pediatric Eye Disease Group, Investigative Group, and this was published in 2023, in which they saw that the suboptimal surgical outcome which is because of the residual exotropia, was much less in this group. There was a superior long-term outcome that the exotropia less than 10 prism diopters. Stereopsis was much better, and there was a much lower rate of reoperation after a period of about 8 years when, for the follow-up. So these are our post-operative patients who underwent unilateral recess resect procedures. They have been on for follow-up with us, and they have been doing well. Thank you all.
Thank you, Smita. Both sides put up a very nice, interesting argument. Anu, anything to add as a rebut?
No, sir. I think one point I'd like to add is Dr. Kushner, who himself suggests that R&R is a better procedure. He said after the augmented LR recession results came in, that the disadvantage of or a flaw in the PEDIC study was that they did not compare it with the augmented LR recessions. The R&R should have been compared with augmented LRs. So that would have been a better analysis of the results.
So one of the major limitations or problems of doing bilateral symmetric LR recessions or even asymmetric is that you can't tackle very large angles. So probably that is one thing that an augmented recession may help, although the larger you recess, the more likely is that you're going to have abduction deficits, and you're going to, particularly in the early period, have some limitation of movement. So, but again, the downside of doing an R&R procedure is, this is my experience, and I think a lot would have shared it. Once the patient comes back after a month or two, he only remembers that the operated eye is smaller. He's forgotten how bad he used to look preoperatively, and all he can remember and keep pointing out to it that this eye is smaller, do something for it, do something for it. So again, both sides have put up their arguments well. Again, local anesthesia, prefer one eye, probably not so great to block both the eyes. But if you're anyway going to plan both eyes, like you're going to do obliques or manage DVDs, probably it may be better, especially if the angle is not too large, to plan for both eyes. It does give a symmetrically better post-op result cosmetically. So I would personally say that, again, the choice is dependent upon the case and what your endpoints are. Every study would have different results. You need to read between the lines. If you take a study which has a larger baseline population deviation to start with, they'll always say R&R is better. If you take intermediate or medium term level deviations, probably both will come same. So I guess, again, as has been pointed out for all debates, it's a little more surgeon preference and your case selections. So thank you. I think both gave a very good presentation. Thank you.
Rohit, one of the very important point in these ideas is recurrence. Because what I have seen in many of these cases, they recur very fast actually. So what do you think, like doing bilateral symmetrical and the 1 hour R&R resection and recession, which gives you a better result in terms of recurrence?
Long-term.
Long-term recurrence.
So I don't think the type of surgery actually makes a difference. IDS is something that we've learned really is the toughest surgery, toughest strabismus to actually tackle, because it is perpetually coming back. And probably a little overcorrection in older population in the non-amblyopic age group may help you to overcome that risk of recurrence. So not really the type of surgery, but your endpoints of your surgery may help you to prevent or overcome. But of course, a lot matters is in the level of binocularity or stereopsis or binocular interaction the patient has, and is able to maintain that to prevent a recurrence of deviation.
Do you find any difference if you are combining both the surgeries? Like you do the bilateral symmetrical recession as well as resection in one eye?
A 3-muscle surgery would be useful for a
in terms of recurrence, I am talking in terms of recurrence.
Like I said, all the studies that I have seen, or even on personal experience, I don't think the type of surgery is actually making a difference, because your recurrence is proportional to the fusional vergence that the patient is able to maintain over a long term. Your surgery is mechanically ensuring that the eyes are able to or get the opportunity to get the fusional vergence in. But if there is a good fusional mechanism in place, any surgery, once it has corrected the angle, is going to help you to maintain that deviation. And as I said, a little overcorrection has been shown to be better in preventing recurrences. So in large angles, R&R is something that you can manage to get an overcorrection in. Bilateral LRs, you have a limitation of the maximum correctable angle that you can, because if you start going beyond, you start having limitations, which is not such a great idea.
So all that as a non-strabismologist I could understand was that all strabismologists put together cannot answer this question.
Absolutely, sir. Although I would disagree with your first part of your statement that as a non-strabismologist you are giving an opinion. I think you have a huge experience among everybody who's here. Thank you.
So, but I'll ask another question. So if a child presents at about 2.5 years and he started showing loss of binocularity, so would you temporize, would you wait till say 3 years of age or more, or would you go ahead with surgery at 2.5?
So I don't actually take age as the consideration in deciding when to operate. So irrespective of the age, if the deviation appears to be significant, if the control appears to be poor, I would operate. We operate infantile exotropias within 6 months of age. So it doesn't...
There are some opinions that the chances of consecutive esotropia
so the
or microtropia.
So the chance of consecutive esotropia is every age. You're worried about the consequence of consecutive esotropias. So I would say that younger age group, I would prefer to probably err on the side of undercorrection when I have a risk of amblyopia, because again, most children are either hyperopic and also have a good fusional version. So a small undercorrection, I would be happy with the outcome because I expect them to be able to correct. And the one thing I would really look for in these children who are presenting early and having poor control is either the presence of obliques, or I am worried that they have poor versions or poor fusion to vision of fusion to work with. So I'm a little concerned about their long-term outcome. So
thank you for a brilliant session.
Thank you.
Dr. Rohit, please join us here. This session I have to thank the Messrs. Elergan for the taking the initiative in initiating and in the conduct of this session. I would like to thank them for this. And we have 2 talks now on subjects of inflammation in dry eye and resistance on antibiotic resistance. So we'll request Dr. Aditi Dusaj to please give us a talk on dry eye inflammation management.
Good evening, everyone. First of all, I would like to thank Padam Shri Professor Dr. A.K. Grover sir for giving me this opportunity to speak in this academic forum, which I accept with folded hands. I am Colonel Dr. Aditi Dusaj. I am Senior Consultant at Sri Balaji Action Medical Institute. And I'd also like to inform you all that sir was recently honored at ICON 2023 at Army Hospital, RNR, on 5th of September, this very month. So since then, I've been waiting eagerly to speak and be a part of this interactive session.
Thank you, Aditi. It is a privilege to have you with us.
Thank you so much, sir.
And I think you should thank us also for having made sure that the Asia Cup final finishes in 21 overs, so that you can all be here not worrying about the results.
So my topic today would be, after all this fantastic debates on cataract, squint, oculoplasty, that dry eyes, with all and fantastic surgery being done everywhere, our patient can still be dissatisfied if the patient does not have a comfortable blinking. And that can be attributed to dry eye, which needs to be addressed, because if that is not done, even after बढ़िया सी surgery हो जाए, femto भी हो जाए, 1-1.5 लाख भी patient खर्च कर दे, but वो फिर भी कहेगा operation के बाद से बड़ी तकलीफ हो रही है. So we need to address this issue of inflammation. So the key mechanisms in dry eye disease are tear film instability, hyperosmolarity, which can lead to apoptosis or cell death, which can in turn lead to nerve stimulation damage, inflammation again, cytokine release, matrix metalloprotease activation, goblet cell loss, and again a tear film instability. A vicious cycle which can be because of lid abnormalities like blepharitis, Clazian, uses of any topical drugs, preservative induced, and all these things ultimately, including LASIK or refractive surgery, can lead to a severe dry eye. Inflammation is one of the key mechanisms of dry eye disease, and it is a physiological response to invading pathogens or antigens. Excessive inflammatory responses can damage healthy tissues of the eye, and affected parts of the ocular system become tender and inflamed, and even visual loss can occur in chronic or severe cases. Consequences of inflammation can be both tissue destruction and neurosecretory block mediated by inflammatory cytokines, reduced reflex tear secretion, which is mediated by the main lacrimal glands, loss of sensory drive to the lacrimal gland, and decreased corneal sensitivity. Patient can present symptoms with dryness, blurring, burning, stringy discharge, foreign body sensation, even watery dry eyes. You tell the patient you have dry eyes, patient will tell you, but meri aankh se to pani gir raha hai, to dry eye kaise hai? So that is a watery dry eyes, which can be because of prolonged reading, computer vision syndrome, digital vision syndrome now instead of being called computer vision syndrome, and because of all of us being seated in air-conditioned rooms especially. Initial patient examination, dry eye may not be initially evident, can be overlooked, but if there's a lack of response to current therapeutic procedures, that can indicate inflammation. So a thorough medical history, including any systemic diseases which the patient may be having, including noting of the patient's symptoms. Order of diagnostic tests would be Ocular Surface Disease Index, which is a list of 12 questionnaire in which patient tells you about his occupation as well as his number of hours on the computer in air-conditioned, non-air-conditioned rooms. Examination of the face, slit lamp examination, tear film breakup time, ocular surface staining, Schirmer's test, and inflammatory marker testing. Examination of the face includes the eyelashes, the lid anatomy, any discharge, any lid surrounding conditions like acne, rosacea, or hyperemia of the eye. Tear film breakup time, we are all aware, values more than 10 seconds are normal, and values less than 5 seconds strongly suggest dry eye disease. Ocular surface staining with fluorescein or Leishman green staining. I usually do a fluorescent staining only. Yellow filter for fluorescein, red filter for Leishman green. Leishman green stains the dead and devitalized cells and identifies areas of corneal and conjunctival damage and death. Schirmer's test, we are all doing in our OPDs. Nowadays, we do have the IRDA test also. LipiFlow and LipiView are again helpful. MM9 or matrix metalloprotease marker, testing for inflammatory markers in multi-speciality hospitals. We can all go in for this test, and patients come up with a good result after the OSDI questionnaire as well. Impression cytometry, though not very common, can be done again in multi-speciality hospitals where we have access to both pathology and microbiology. Standard therapies would be patient education, environmental and dietary modifications. The first line of defense is artificial tears, lubrication of the ocular surface. Do not directly address inflammation. Patients with moderate to severe dry eye disease should be considered for anti-inflammatory therapies. Treating inflammation on all these lines. Initially, we do start with all types of artificial tears. Then a patient can be put on omega-3 fatty acids, autologous serum, oral tetracyclines, corticosteroids as initial line of treatment in treating inflammation, and then cyclosporin A. Cyclosporin A has been approved by FDA in 2003 for treating patients with dry eye disease. 0.05% is one which we all generally use. It is oil-based ophthalmic emulsion. The potential mode of action of cyclosporin A, which we consider as an immunomodulator, it basically inhibits T cell activation, inhibits leukocyte migration, inhibits pro-inflammatory cytokines, and activation of antigen-presenting cells. It protects the epithelial cells from apoptosis. In which patients do we start cyclosporin A? Patients whose tear production is suppressed due to ocular inflammation associated with dry eye disease. Patients with dry eye disease associated with Sjogren's syndromes, which can be primary or secondary. Cyclosporin A targets the cause of dry eye disease and may alter the course of disease. including Schirmer's, diaphragm breakup time, staining, and OSDI. Patients who used Restasis have shown a mean changes from the baseline of Schirmer's of 24%, diaphragm breakup time 34%, staining decreased by 17%, and the ocular surface disease index by 22%. Cyclosporin A therapy resulted in improved signs and symptoms of dry eye disease. Patient was highly satisfied, but for the initial hiccup of the high cost, fewer ophthalmologist visits, and less ancillary drug use. Efficacy improvement not only depends on active but on whole formulation itself. The vehicle for cyclosporin A ophthalmic emulsion provided substantial palliative benefits. One of the factors contributing to the beneficial effects of the vehicle may be a sustained residence time of the oil component on the ocular surface, which may help reduce the evaporation of natural tears. It significantly improved the signs and symptoms after 6 months of study 2, and adjunctive therapies initially which we can use is patient can be started on corticosteroids along with artificial tears for initial 2 to 4 weeks. Then the effect of cyclosporin starts taking over, and then you can slowly taper off the steroids and continue with cyclosporin A with artificial tears. It has even shown to increase the goblet cell density after about 4 months of treatment. The treatment plan for cyclosporin A is twice a day, 1 drop per eye. Like I said, the effects begin after 4 weeks. Duration of treatment can be lifelong. I have been using, few patients have been using for around 3 years also now, and patients don't show any blood concentration increase of cyclosporin. So patient education is the main key for a successful cyclosporin A treatment. My personal choice is 0.05% cyclosporin twice a day, both eyes. So in the end, to summarize, I'll say inflammation is one of the 4 key mechanisms of dry eye disease. Stimulation of inflammatory mediators results in a positive feedback loop. Examine the patient well, including the face, the lids, and ask him or her about any systemic diseases and treatments for any allergy, for any arthritis or any joint pains. There's a wealth of therapies treating inflammation, including artificial tears, antibiotics, cytokine inhibitors, autologous serum, corticosteroids, and cyclosporin A. I thank you for your kind attention.
Thank you, Dr. Aditi. As we are all aware, the commonest condition that we treat in our OPDs is dry eye. There is no question about that. And that inflammation plays a very significant role, has been emphasized repeatedly again and again. And the importance of controlling inflammation as a means of controlling dry eye is very well understood and very well emphasized. And we all know that the role of steroids initially, but low strength steroids which can be tapered off rapidly and then go on to something that can be used in the longer run, and the use of cyclosporin is also rather well established. So I think she covered the entire huge subject of dry eye disease, including evaluation, including the basics of therapy very well in the short time.
Thank you, sir.
Thank you very much. We'll take a single comment from one of you and then we can go on to the next.
Excellent presentation. One important point in dry eye disease, especially because when we are looking after the operated cases, as you are saying, because they keep on complaining the symptoms of dry eyes, even if you do a very good surgery. See, dry eye, actually, what you have to look into is like whether patient, the inflammation part, it's a surgical inflammation which is inducing the dry eye, or it's the dry eye which is inducing the inflammation. So if you are able to differentiate between these two situations, then I think the management becomes quite easy.
But I would again like to add, sir, that any cataract surgery or any surgery which you are doing, whether it is refractive surgery or whether it's a cataract surgery, starting artificial tears at least 2 weeks before the surgery does help in taking care of the initial damage, and patient will be a happier soul post-surgery also if you continue it for 2 to 4 weeks.
And we also have to be careful of the fact that many of these patients preoperatively also suffer from MGD. and
Correct.
which worsens after the surgery. So any patient having coexisting cataract and meibomian gland disease need to be treated well for MGD before we take up these patients for surgery, because they keep on persistently complaining. So we have to, besides the other the resurgence and aggravation of the dry eye, MGD also has to be taken into account.
And MGD
nowadays
is
even
such a common entity over the age of 50
And
years.
we have hot and cold eye mask. The hot part can be used for taking care of the lid inflammation. Patients are really benefited along with artificial tears.
Thank you, Dr. Aditi.
Thank you so much.
And now we have the other important subject that we would like to tackle, which is the resistance to antibiotics. And we have Dr. Tushar to tell us something about that. I think this is a drug resistance is a very important factor all over globally, recognized as a very vital thing, and which should dictate what we carry out as clinicians for our subjects.
So good evening. Can I have my slide there? So thank you so much. Good evening. I'll be talking about antibiotic resistance and how we can choose the right antibiotic. So we know that antibiotic resistance is a global concern now. It's been called a global pandemic, and it has changed the trend in us managing individual cases. It has impacted society as a whole and also changed the economics of managing infections. It has also had an impact on us choosing to empirically use antimicrobial compounds, because resistance is a big issue now. So currently what is looked at and what is commonly talked about when it comes to antimicrobial susceptibility is the minimum inhibitory concentration, or the MIC. So essentially, if a particular organism shows a low MIC to an antimicrobial agent, that means you have a high chance of clearing that infection, whereas if it's a high MIC, that means your chances of success with that particular antimicrobial agent are low. But the new measures that are being talked about now, which is specific to trying to prevent resistance, is mutant prevention concentration. So this is something which is looking at the possibility and in fact the probability of having mutant subpopulations within the overall bacterial infection. And this MPC drug concentration is higher than the MIC concentration, because you are trying to not just get rid of the active infection, but also trying to prevent the development of resistance. So this is a graph that shows that. So what you see in the red is the mutant selection window. So this is a dangerous area where you've been able to get rid of the active infection because it's above the MIC, but not been able to prevent the development of antimicrobial resistance here because it's below the MPC. So ideally, whenever you're treating an infection, the concentration has to be higher than the MPC so that you prevent the development of resistance. Now, having said that, drug resistance comes in various shapes and sizes. Here are some cases that I have encountered recently. This was an extensive graft infiltrate, which was found to be resistant to most antibiotics. In this case, it was sensitive to only gatifloxacin and to vancomycin. This was another case scenario which showed fungal growth to begin with, but subsequently was also found to have diphtheria, which was resistant again to most antibiotics, in this case being sensitive to cefazolin and to ofloxacin. So it's variable. That's why it's important to look for the etiological agent and check for the sensitivity and then treat. This is another case scenario of a contact lens infection. This is a Pseudomonas that was encountered resistant to absolutely all antibiotics except colistin and piperacillin tazobactam combination. So this patient did actually respond well with colistin. The antibiotic resistance monitoring in ocular microorganism surveillance program has shown also that moxifloxacin resistance is on the rise. Even in the Indian scenario, a study by Dr. Lalita Prajna had shown that susceptibility to moxifloxacin was as low as 61.2% in coagulase negative staphylococcal species and 53% in methicillin sensitive staphylococcus. So this is another study which looks at the in vitro susceptibility of bacterial keratitis isolates, and this in fact found that gatifloxacin showed a good sensitivity. Most common gram-positive organisms were susceptible to gatifloxacin, and both gram-positive and gram-negative ocular isolates were more susceptible to gatifloxacin than moxifloxacin. This is another study which looked at the bacterial load in the conjunctiva And here again, gatifloxacin was found to reduce the conjunctival bacterial flora and showed better retention. Of course, then when you have these infections which are resistant to everything, the options that do work in most cases is linezolid in cases of gram-positive bacteria. Colistin still works in a majority of multi-drug resistant Pseudomonas cases. And imipenem is something that works with nocardia and atypical mycobacteria. So it's important for us also to be responsible, to take measures to prevent the spread of antibiotic resistance. It's important to choose the right dosage. If you're using a very low dose or giving antimicrobial therapy for a very short period of time, we might in fact actually be promoting the development of antimicrobial resistance. Also, tapering antibiotics is never a good idea because again, you're promoting antimicrobial resistance. So antibiotics should be given for a fixed period of time and then discontinued, and it should be the right dosage that should be maintained. Also, it's important for us that we, especially in cases like keratitis, endophthalmitis, we try and identify the pathogen, look for the sensitivity, and then treat accordingly. Hopefully, we will have better availability to rapid tests like PCR or PNA fish soon in the future, so we don't have to wait for culture results and sensitivity because that does take a considerable amount of time. And also, it's important to try and avoid using antibiotics when we know that there is not much proof of tangible benefit. So in cases like viral or allergic conjunctivitis, we can avoid using antibiotics because they might not help but will promote antimicrobial resistance. So to summarize, antibiotic resistance is a rising concern and we are dealing with it. India has been described as the antimicrobial resistance capital of the world. Isolation of microorganisms, trying to identify sensitivity and resistance is always a good way to approach a case and treat according to the reports that you get. When you're administering fluoroquinolone monotherapy, gatifloxacin is likely to be more effective than moxifloxacin. That's what some of the data is showing now. And avoid indiscriminate use of antibiotic wherever they might not be necessary. Thank you.
Thank you. I think this is a very, very pertinent topic to be brought. And personally, I fear that as ophthalmologists, we are rather, culpable in the fact that we are generating a lot of antibiotic resistance because a lot of the drops we put in the eye go via the nasolacrimal duct into the system, into the gut, and where it reaches in very micro concentrations, encouraging the bacteria there, including the commensals there, to get access to a very small suboptimal dose, which allows them to actually get ability to develop resistance. So that's the best way resistance develops, is when there is suboptimal concentration of a drug, as you pointed out, that you need much higher concentrations that you do. The other thing you very nicely pointed out, which is a very wrong practice among ophthalmologists, is that they use a combination therapy of antibiotic steroid, and because we are tapering steroids, the antibiotic also gets tapered. So that's a very, very wrong practice on our part. I think you very importantly highlight. The other thing I would also want to add is that do not use the drugs that you are using for therapy of infections as a prophylaxis. So while moxifloxacin is the flavor of flavor for the ophthalmologist, it's also currently still as a therapeutic drug for infection. So preferably use, say, tobramycin or something as your prophylaxis, where you just want to sterilize or reduce the concentration of microorganisms before, say, a cataract surgery or a surface procedure. So I think a very, very pertinent point. I think it's high time all of us. The one other thing which Dr. Grover and people at Power could do is actually get the latest antibiotics to be available only on prescription and not over the counter like it is. So that would, the other thing that would go a long way in preventing development of resistance in the newer generation antibiotics that we're getting.
So looking at the result, what you have shown, the resistance, because it's very scary. Like all the drugs you have shown are resistant and very hardly available, one or two drugs to treat these fulminant corneal ulcers and so many problems in the eye. So, and you have very nicely shown that the MPC value and MPC and the second one was MIC value. So MPC, like you increase the concentration but you have to be very sure like what concentration you have to go in for treating these, because we are already using very high concentrated vancomycin and other drugs. But then the increasing the concentration only is not the solution, because you have to be very careful, like Dr. Rohit already said, like using indiscriminate use of these antibiotics has become the problem of resistance. And then we'll end up with the problem when we actually need to treat these situation with a special antibiotic.
True. So also a good concentration at the tissue level can be maintained by more frequent dosing as well. So at least making sure that we are giving the dosing which is optimal and not suboptimal will also ensure that in majority of the cases we'll be above the MPC and not just above the MIC as well.
I think very nicely summarized, Tushar. The concept of MPC is definitely important, and you said MPC is about 10 times the concentration of MIC. So if, in short words, if it is 3 microgram per ml for moxifloxacin, it amounts to about 30 microgram per ml. And second important thing is, do not use antibiotics in the cases where you don't require it. Like in the current epidemic of the adenoviral conjunctivitis, people are using moxifloxacin left and right. And that, I think, we are really responsible for increasing the antibiotic resistance. And you said in the studies done by Lalita et al., 61% and 51% already have resistance to moxifloxacin. And moxifloxacin is a drug which we are using even for intracameral prophylaxis. Imagine if we use indiscriminately and we develop resistance, what are we going to use? Not drugs like vancomycin or the cephalosporins, which have their own problems. So we need to have some drugs reserved for these resistant infection, and it's drugs like, I think, chloramphenicol should again be started, because resistance to those drugs is still not occurring. And unfortunately, those drugs are not available. And we, in the fashion of using more fluoroquinolones, 4th generation fluoroquinolones, are forgetting the drugs which may be effective in the milder or moderate, I think, bacterial conjunctivitis cases.
Thank you very much. We will now start with the, please stay there, and we are now starting the exciting panel discussion on the future of ophthalmology, and are we going to see a change in the face of ophthalmology? Can you have these slides, please? Full screen nahi hoga? Full screen. So we are joined by some specialists for this field to help us with this. We have 2 more ophthalmologists, Dr. Ritin Goel, please, who's a consultant at Goel Eye Institute and an excellent surgeon, and Dr. Bhupesh, who's an excellent cornea surgeon. Both of you I'll request to join, and I'll request Dr. Apoor to please join me in moderating this session. And we have some specialists here who have agreed to be a part of this program, and it is stupendous to have Dr. Veronica Arora with us, who's an excellent young achiever who's won many awards for her initiative and work in gene therapy and genetics in general, and is a part of the Sir Gangaram Hospital. And and there are 2 experts in AI who are joining us from abroad on the Zoom. And I welcome Dr. Anandraj Pandya. Is he connected? Has he joined in? Dr. Anandraj Pandya, welcome.
Yes, I am joined. Yeah.
Welcome, and we look forward to your inputs for this session.
Thank you.
Dr. Anandraj Pandya is a Shell petroleum expert he's working with the company to lead them in the direction of the artificial intelligence. And Mr. Guru Baran from Verizon. He's a principal machine learning expert in Verizon, and he's also joining us to guide us on this very important subject. So we have an exciting discussion to come up, and may I request Dr. Apoor to please start the proceedings. And I'll, most importantly, Dr. Bali, Jatinder Bali, who has been helping me with the framing of the questions and with getting these 2 experts to us. Dr. Bali, please join us. Please join us. So we look forward to inputs from the audience as well, because this is something which will change the face of clinical ophthalmology as we practice today, and in many ways the future is already with us. So let's see how things go. Dr. Apur, can you switch places, and can you...
Hello, yeah, I'd like to welcome our AI experts here, Mr. Anand Raj Pandian and Mr. Guru Baran. Now, yeah, I would like them to
Dr.
just...
Guru Baran, can you just say hello to us? Mr. Guru Baran, thank you, welcome, and we look forward to your inputs too.
You are in mute, Guru Baran.
Okay, welcome.
Sorry, I was talking on mute, and I'm pretty excited to talk on this forum and all this. It's my pleasure.
Thank you for joining us. Now, we'd like to get your inputs on how AI is likely to transform medicine in the coming years, and how do you think it can impact in the way the treatment and our diagnosis, and how do you think AI will come up in the field of medicine over the next few years? What role do you think it will have?
Actually, I'll give a background to this. Both these gentlemen have been working in different projects, and all of us are aware that artificial intelligence has been coming up in ophthalmology, in cataract surgery. We're picking up cataracts using slit lamp images, using fundus photographs, and it is possible to even refer the patients and decide whether you want to go in for a surgery or not. And then of course you have all these IUL power calculations that we've been doing. What we would like to actually, what we want to know is how is it, is the future already here? In terms of, you see, there are many stages of artificial intelligence. So if you could please walk us through the stages of artificial intelligence. I think we've lost him, sir.
Go through the gene therapy part first and then go on to the AI part. The first part is we are starting. Can we have? Okay. So we'll first go about with the basics of the very basics of how the gene therapy is shaping up and why does it work and how does it work. So we'll start with the inputs from Dr. Veronica on gene therapy. How does it work is the first question.
Thank you so much, sir, for this opportunity to have me in the panel. So gene therapy, as the name suggests, is the therapy or the treatment of the defective gene itself. So the procedure is basically when you take a gene which is corrected from outside, from an external source, you integrate it into a viral vector, or there are many different types of vectors that are available. There is an integration process of a gene with the vector, and after we integrate this gene into a vector, we need to inject the gene at the site of action. So for this audience, we will concentrate obviously for the eye, and eye is an excellent candidate for gene therapy because of the ease of administration and a direct possibility of administration of the gene therapy. So once there is a corrected gene in the viral vector, it is inserted into the place where the gene is required the most, here eyes. So when we have a corrected gene that goes inside the site of action, it integrates into the DNA of that site, and then the corrected genetic copies starts getting produced in that portion of the body. So wherever we need the site of the gene to act and where we know it is most required, we take a gene, put it in a viral vector and insert it into that part of our body.
Yeah, so I wanted to ask you a couple of questions on the gene therapy that is likely to be available in ophthalmology in the near future. Now, We do know that Luxturna, the RPE65 gene has been approved, gene therapy has been approved by the FDA. Now, I wanted to ask you on what's the age group that is likely to benefit from this, and how can we make it available to our patients if we have a patient who's willing for the surgery at the moment?
So before we get to who can we give it to, we need to understand when we can give it. So we have a patient with retinitis pigmentosa. It is important and almost mandatory now that we do a genetic testing. The test of choice could be a panel of NGS or it could be an exome sequencing. Exome sequencing will look at all the genes which could cause retinitis pigmentosa, and once that gene is identified and if that gene comes out to be RPE65 and there is a mutation in RPE65, only then can we think of advising a patient with Luxturna. So the first step is to do a genetic test, which is a blood-based test called exome sequencing. In that test, if we get RPE65, we can discuss with the patient the probability of gene therapy. It is approved for patients, for children more than 1 year of age and all adults. And what was your second question?
How do we make it available? Do you think it will be available in India in the near future, or if there is a patient who's willing for the surgery, do you think we can make it available in India at the moment?
So yes, there is a patient, a common patient which we also have and are discussing gene therapy about. It is very well available in India, but of course due to a lot of challenges of at present the expertise of administration, no patient really has up to my knowledge received this gene therapy. So we can definitely arrange for gene therapy, a training of the retinal surgeon in the procedure, and the patient can benefit from it.
So at the present moment, it is available, I mean, at least it is available as an approved therapy for a very limited condition, which is the gene that you have mentioned, the Leber's
congenital amaurosis type 2 or RP65.
Yeah, so that's the only condition where it is approved.
Approved, yes.
But what we are looking at is it going to have a lot more future application? Look at that picture. Are we going to get results like that someday?
Sir, so the purpose of genetic therapies is to correct disorders, not variations, which are actually beautiful in humans. So we don't aim to do that.
So let's tell us, what do you think are likely to be the future applications in ophthalmology in the coming 5 to 10 years? And then I'll request Apu to please explain as to how this gene is actually placed in the clinical setting. How is it being done? So first tell us, what do you see as the role in the coming 5 years?
So we have rod cone dystrophies in which there are many gene therapy trials going on. There are other genes except RP65 for which also gene therapies. Now we have a phase 3 trial as well for other genes unrelated to RP65. So the two main groups of ophthalmological disorders where gene therapy is ongoing is dystrophies, retinal disorders. I think mostly because cataracts and squints can be managed better than retinal disorders by surgery. So that was, I guess, the...
We agree. Retina surgeons don't do anything.
Yes, so there is a test for color blindness, and that also is a monogenic disorder. That is, it caused by mutation in the genes. We don't have any therapy for it because it's not a very life-threatening sort of a condition. But there is a test by which we can do it and also predict if the future generation will get it for the red-green color blindness. It's an X-linked trait. That's why more in males.
Veronica, what we want is, give us an overview of how it is going to impact medicine as a whole in 5 years. So, what are the conditions systemically that we are looking at where you think you will be able to make a difference in the coming 5-10 years?
So at our hospital, at Gangaram Hospital, we are already administering gene therapy for spinomuscular atrophy, which is a condition in which children are hypotonic and not able to walk. They have respiratory insufficiency and failure very early on in life. It's a 16 crore therapy, but we are providing for the patients, that is free of cost. Now gene therapy is approved for thalassemias, for other hemoglobinopathies like sickle cell anemia. We have gene therapy for adrenoleukodystrophy, which also a lot of time has an ophthalmological management. So actually from head to toe, there is a gene therapy for dilated cardiomyopathy, for long QT syndrome, very recently for Crigler-Najjar syndrome as
Okay,
well.
so you are telling us about the rare conditions. What we are interested in, will you eliminate diabetes for us tomorrow? Will you eliminate myopia as Rohit Saxena has been trying to do for years but has not succeeded? So will you be able to eliminate those conditions in, say, okay, not 5 years, not 7 years, 20 years?
So I think
I give you
as
more
long
time.
as we all in this hall live, we will only be able to cure conditions which are very severe and maybe not reach up to myopia in our, because we are really targeting very severe disorders, and first we deal with those and then maybe after that we reach there. So there is now a RNA based therapy for hypertension. So but of course it's very expensive, but is approved. So for hypertension, we do have a gene therapy that is RNA based. It's injections which can be given once in 6 months. So people who are affording and who don't want to take so many antihypertensive can very well use that.
So even for this 65 gene, this is the 6th costliest drug. It is a few crores right now, isn't it?
2.5 per eye, yeah.
So
2.5 crores per eye, yes,
yeah.
yes.
So it's still for rare diseases at this moment.
The systemic, no. Ophthalmological, I think Dr. Apoor
And how do you
can
inject
speak.
it? How do you clinically give it?
At the moment, it does require a subretinal injection, so it requires a complete vitrectomy, and then following that, the drug, shallow retinal detachment has to be induced close to the fovea, and then the drug has to be injected subretinally. That is the mode where it is said that it is likely to be the most effective, because intravitreal injections often do not reach the outer retinal layers. So yeah, even I would like to ask my vitreoretinal colleagues if they have experience with subretinal injections for other conditions, and do you think this is a mode of treatment which is likely to have high risk of iatrogenic damage, or do you think subretinal injection can be performed safely on a consistent basis?
But before that, the advantages that have been shown. So the trials did show that there was a benefit at least for 1 or 2 years in a fairly large group of patients. So just tell us a little bit about the results that have been achieved.
So it has been almost 8 years since this therapy has been approved, and it is being given in a lot of hospitals in the USA. So the longest follow-up has been of 5 years, till which the effect of the gene therapy lasts. So it is said that it is a one-time injection, but that is the best case scenario, and the level of the DNA that we inject does decrease with time. So there was an increase in the vision, but the sustainability of that is still in question, because the highest time that has been is about 8 years, of which we only have a 4-year follow-up, and there was mild decrease in vision after the 4 years.
But there are several centers with very large subsets of patients which are being done globally. So we'll switch to...
So interestingly, what Apoor mentioned, there's very recently been there's a new robotic system which has performed very well in pig's eyes, and it is consistently delivering the dosages subretinally. It is capable of doing your hydrodissection of capsulorhexis, of hydrodissections, but it's only in pig's eyes that they've managed to do it, not in human eyes as yet, sir.
So we are looking at a future where there may be a lot of modifiable things. Rohit, what do you think?
Just I wanted to add that besides retina, of course, Leber's hereditary optic neuropathy is one thing where a lot of advancement has happened. Particularly, it's easily accessible because it's a mitochondrial DNA which is being modified. So, what is there any, I mean, information or access? Because unfortunately, I don't think of any trials in India, but there are a fair amount of trials internationally which are fairly positive in their outcomes.
Yes, sir. So nothing approved as yet. There are trials, and the trials are RNA-based therapies which will go and modify the mitochondria. The thing with RNA-based therapy remains that RNA has to be continuously renewed, and we have to give it again and again. So if there is a patient of lawn also, we can try and get them into a trial abroad by applying for it. So, but nothing in India.
There is
so you said many of diseases you are already injecting these drugs, especially in the systemic disorder, not in ophthalmology. Do you find any very serious untoward effect of the injection?
Yes,
there are certain reported, like even the death has been reported.
So death as a cause of gene therapy, we have not experienced. The kind of side effects that we have seen is deranged LFT. Most of these gene therapy have a first pass metabolism through the liver, the systemic ones. So the LFTs are most often deranged, but not any major side effects that we've encountered up till
It's
now.
because of the gene, or it's because of the mediator, like the virus?
The metabolism that occurs post gene therapy goes through the liver. So because of that one, and the other side effect that was present earlier, not now, is when we used retroviruses or HIV viruses for gene therapy. At that time, they integrated into the genome and caused cancer or HIV itself. So those are the theoretical possibilities which are present as the side.
Even in glaucoma, there is publication that they have identified in pigmentary congenital glaucomas and open angle glaucoma some LAC-Z reporter gene, and then they identify what are the genes responsible for apoptosis, and then apoptosis inhibitors like BCL6 have been tried, and they found in animal studies to be effective.
Yes, it's animal studies, so no human trials. So human trials are going on for retinal dystrophies and rod cone, but animal trials are going on for glaucomas and lawn as well. So yes, definitely.
So I think we'll very briefly now go on to stem cell therapy before we get our AI experts in and have a more detailed discussion on the AI. So stem cell therapy is something that has come up in a big way. So I thought we should just touch it briefly and take the advantage of the expertise of the panelists on that.
So I think
stem cell therapy, look at that scenario, Veronica. Will we see something like this in 5 years, 10 years? There's a lot of work on stem cell therapy going on.
So I think in stem cells we are much ahead of gene therapy. So in cornea, so we are getting excellent results, especially by SLET in cases of limbal stem cell deficiency cases, chemical injury cases, and results are excellent. Risk of rejections are much less, and no harm to the donor area. That is the best part. And if you talk about the stem cells in diabetic retinopathy or in ARMD, although many surgeons have started injecting, but still we are waiting for the good trial. But I think the future is very bright for stem cells in ophthalmology.
Yeah. So what will you like to add, Veronica?
So I'll just like to add that stem cells are unlikely to work in retinal disorders, and the important place where stem cells work is the cornea. And so there are 2-3 types of stem cells, as you had shown in the previous slides. So can you go back to the previous slides? Yes. So there are somatic stem cells. Somatic means tissue specific, and then we have a pluripotent stem cells which can actually get converted into any lines. Once the somatic stem cell is taken, maybe from a skin, then we make it an induced pluripotent stem cells. That is, we convert a tissue specific stem cell to a more we can say a generalized stem cell, and again it will differentiate and start producing the in the area of activity the cells which have been degenerated. So this is best achieved in corneal disorders, and but we have not had any experience at, I think, our hospital for this.
Anything to add, Ritin?
So just to make this a little more clear, if you look at stem cells, pluripotent stem cells are like those from the umbilical cord. They can form any cell in the body. And then we have oligopotent or just single potent, like that's what we're using, Bhupesh. You know, when we look at limbal stem cells and we're using it to reepithelize the surface, or mesenchymal cells to form the stroma, these cells can't change into retinal cells, and that's, I think, what Dr. Veronica is talking about. And because the retina is so highly specialized, if you're going to use stem cells and try to put it in the retina to cure retinal disorders, it's unlikely to work. Gene therapy seems
But there
like...
are a fair amount of retinal studies that are going on.
Yes.
In fact, I'm very glad to say that there is one Indian company that is just about to soon, hopefully the moment they get their regulatory approval, are going to go into a multicentric trial for gyrate atrophy, retinal stem cells. So obviously, yeah, they are pluripotent cells, or they are like human-induced cells which have been kind of stimulated to become in an appropriate environment to kind of resemble RPE cells, and then they have been injected subretinally, and now even a patch is available which is actually going to replace the brush membrane with the RPE cells over it. And they are supposed to be, in fact, the trials are there internationally, and like I said, we're really looking forward to the Indian trial, where, whenever it starts, where they're going to put this underneath the retina, subretinal, right next to the macula, and hopefully we will get some.
So there is a lot in the corneal stem cells that we've been hearing
that's,
of.
I think, been a
but
very
I
long
think
time
the
now.
future where millions of people are waiting for are the day where you have the retinal dystrophies, abiotrophies, and the age-related macular degenerations, and the optic atrophies for various reasons, who have this as the only hope.
So I have two questions here. Is there a case for preserving the umbilical cord cells? A, and is it available? Is it available within our this thing?
Yes, sir. So there is, I think, whenever a baby is born at present, they've been given an option of saving the umbilical cord cells in many of the cord banks. One of the company which does it is LifeCell, and they're pretty good at it. You need to pay a certain amount every 4-5 years for it. But actually this is a very common question we get asked, that is it useful? So at present, the utility of saving these stem cells against the price these companies ask for storage is limited at best.
So what's the ballpark figure for the storage?
So the cost?
Yeah.
So I think at inception they will cost around 2.5 lakhs, and then every 3-4 years you need to pay a certain amount. So if there is a family history of a retinal disorder, of a hemoglobinopathy, or of any hematological malignancy, then it's advisable to store. For a general public to store stem cells.
So I think we'll now go on to the area of the artificial intelligence. I'll request Dr. Apu to.
So just before you start, can I ask one more question, which I think bridges between genetics, as gene therapy as well as stem cells, is how is it that you are, we're talking about injecting gene therapy into the retina with a viral vector, and we're hoping that it will replicate in the area without using stem cells, you know? Wouldn't you have to have replication there? Is the virus going to replicate and then incorporate? Yeah.
So the DNA that we inject, that's the vector DNA, it gets integrated into the host DNA, the one which is present inside the eye. So once it gets integrated, it starts producing the corrected copies. So that's what the protein. Yeah.
So please go on to artificial intelligence, and we'll start with the very basic.
So I'd like our experts here. Thank you for waiting for us to start the discussion. So I just wanted to guide you on the basic. I just wanted you to guide us on the basics of what AI is, how it works. Can you Yeah.
Request Dr. Anandraj first to give us basics of what artificial. This is a lay audience, ophthalmologist. So you have to first tell us what artificial intelligence, what we should understand as clinicians from artificial intelligence first, before going on to talk about its usage for us.
Yeah, sure. I hope you can able to audible, right? You can able to hear, right?
Yeah, very well.
Yeah, sure. So as I mentioned that the artificial intelligence, so it is a peak over there. But before artificial intelligence, so basically you guys needs to understand what we are trying to achieve here. So we just computer to make the intelligence. So normally computer don't have intelligence. So what we are doing here is we are making the computer to be intelligence. So that is the basics of things. And artificial intelligence, we have a large characteristics will be there. So when we start from the basics, so initially we have the machine learning. What basically it will be do here is we provide the data to the algorithms. When you say algorithm, it's kind of program. So the algorithm, what it will do understand, it will be understand the pattern out of the data which you guys are feeding. This will be understand the pattern and it will be predict the future values. Let's say example, if you are providing some numbers, let's say you have a mileage over there, that's from given time, these are all the mileage will be there. What will be the mileage when we have the next year? So like the predictions, we can able to do this through this machine learning. And next area which we are talking about here is for the deep learning. This is again the subset of the machine learning. So we just provide the different, like human neurons will be there, right? So like that, so we do have a neurons over there. So artificial intelligence, it will be the deep learning, it will be tune the data and it will be give the different layers and it will be trained deeply on the data and it will be produced the results. So, and the deep learning, it is again, as I mentioned, it's a subset of the machine learning. And if you talk about next topic as a natural language processing, this is another branch of the AI. Now I think you are everybody now the peak of everything you are aware of the ChatGPT. ChatGPT, I hope you everyone aware, right?
Yes.
So this is rightly they are booming of the LLM based on. This is the part of this NLP only. So we have a natural language, how the computer can understand and respond to them. Let's say example, I'm going to how I can talk to the bot and how we can overcome. It is responding. Those things has been covered over this in the natural language process. And next is like a field of the computer vision. So the computer vision is nothing but our visions will be the like computer can visualize it. Let's say example, how can computer can identify the images. Let's say if I'm providing the cat, it will be identified this is the cat. If we may pass the image to the computer vision, the system will be identify whether this is the cat or dog. So I'm just giving the layman explanation. It has a more capability will be there for the computer vision. And these are all the mainly focused area for the artificial intelligence. So I just recap. So AI has the different subset of layers will be there. One is machine learning, deep learning, and natural language processing, and computer vision. So I hope this will have some basics about what is the AI.
So thank you very much. I think you've given us a basic concept. We know that AI is going to be life-changing for all of us. It has already made a lot of difference and it is going to make a lot of change. So I'll request Dr. Bali to please now request Dr. Gurubaran to give us the explanation once again for the jargon that we hear, the machine learning, the deep learning, the neural networks.
Yeah. So, Guru, if you could please take us through neural networks, artificial neural networks, generative AI, and machine learning.
What should laypersons understand from them?
How do they differ?
Yeah, I'll give a layman perspective, and thanks for giving this opportunity, Dr. So, as Anand said, right, so basically artificial intelligence, right, let me lay out how do you define that term, right? So, we humans, we innately have this cognitive abilities, right? By the time we born, we were able to perceive things through a visionary organs, and then you can hear things, we perceive things, and we make decisions, and based on the environment, we're able to understand the environment, we're able to take decisions based on that, right? So this is driven by the brain, and we have multiple thoughts in the brain. It acts for each of the decision making. So basically, we as a human, whatever we get, as a natural intelligence, the cognitive abilities, right, which we are trying to mimic it through a machine, right? That's when we call it as an artificial intelligence. Artificial is a machine trying to mimic the intelligence that is innate with human beings, right? So by doing that, we get a lot of benefits, but basically the artificial intelligence definition is that, okay? Any natural intelligence, we are trying to do a biomimic through a machine. That's what the artificial intelligence. So it's this machine learning or deep learning or neural network for that matter, it's just one part of the puzzle, right? Artificial intelligence is a broad area wherein, the robotics, right? For the motor movements, we need robotics. For the vision, to interpret visual aspects, we need computer vision. Through machine, how can I interpret a visual object or a video, image, or for that matter, how humans perceive things, right? And then natural language understanding. Only human beings can understand different languages, and they interpret, they can have even emotions, right? So emotions, NLP. So to really impart the knowledge that human has with a machine, we need many aspects. This is just machine learning is just one part of it. Computer vision, natural language processing, text-to-speech understanding, expert system, robotics, all this plethora of things put together, we call it as artificial intelligence. Since machine learning and deep learning has been talked about, right? It's been shown as an artificial component of artificial intelligence. But machine learning, if you see, right, it's just one subset of artificial. In machine learning, if you take, right, it is through data-driven way. You guys, through a lot of clinical trials, right? Statistical way, you take survey, and after taking a survey, you do a hypothesis, and you come up with an understanding of the hypothesis, right? So all you do, all of these things you do based on the data. Similar way, using some classic machine learning techniques, mathematical paradigm, if you're trying to do, classify whether it's positive or negative, or if you want to regress something, right? If you try to make some insights through a machine in data-driven way, it's called machine learning, right? And deep learning is a subset of machine learning. So deep learning is a biomimic of our neurons, right? Typically in our brain, we see signals and it goes through a network of neurons, and after it going through that, you're trying to come up with a prediction about the thing, right? If you see a dog.
See, we used to talk of, artificial narrow intelligence, artificial general intelligence, artificial super intelligence, and singularity. Yeah. So, can you walk us through those?
Yeah, I'll walk us through that as well. But I hope you got what is deep learning, right? It's
yeah. So basically, what he's saying is that, you see, we have machine learning as a broad subset. Within machine learning, we have a subset, deep learning. These are data driven. You have the data. From the data, it is deriving algorithms, and using that algorithm, it will make a prediction for the future. So it is possible, whatever truth we are finding or whatever the algorithm is fitting to is fitting to the data that we have. How good or how generalizable is this algorithm to the other population? That is the task of the contextual learning of machine learning aspect.
So there is a huge amount of input that is needed, and it's the quality of input which will determine
quality of data sets is important,
which will determine what we get out of it. So this is what will be important to us as clinicians, as ophthalmologists, or as medicine people, that it is from the basic data that has been accumulating, more and more data, more and more levels of understanding that has come from it, that it has led to multiple levels of the
Thank you so much, sir. This is what I wanted to bring it down to. You see, we have a lot of people here who are working in healthcare and in ophthalmology. And all of them are generating high quality data. So actually, it is the quality of data rather than like the amount of data also, but the quality of data has to be good. So how can, if they want to plan something, what should be the steps that they should, how to go about defining a problem and how to...
So now we are at what does artificial intelligence you think can do in the field of medicine, and then we'll go on to ophthalmology. So what I would like first Mr. Anandraj to tell us is how do you foresee its role in medicine, and then we'll talk about ophthalmology. So with what you know about the AI and what you know about the data that is being collected, what has been the progress in medicine and in ophthalmology? That's what we would like you to now emphasize.
Yeah, sure. So what I was seeing in the field of healthcare, so being there, I've been there for healthcare, I think 5 years back. So we used to do some kind of the personalize the medicines. Let's say example, for each person, so we have some disease over there. So what we have to do, we have to take the specialized, personalized medicine for each person. So something like, so based on the machine learning, we have trial out this one, and just collect the medical history to tailoring the treatment. Let's say example, I want to make the tailor-made the treatment, so I have to collect the medical history, and for each person should be treated as a differently. So what basically we'll do, we collect the medical history of each person, and what are he has a background of these things. Everything will be fed to the model. The model will be give the tailor-made treatment for each person. So this is the one thing which I have worked previously. And next thing is what I was thinking in the year of now, there is a drug discovery. Let's say example, AI can accelerate the drug discovery by analyzing the different type of data sets to identify what is the potential can cast the drug to candidates. This combination of chemical can provide the better results. So like that, we do have the kind of drug discovery. We can use this one. And next thing is what I was thinking here is for the disease detection and diagnosis. Let's say example, we have the analyze the medical images. Let's say example, X-ray, MRI, CT scan to detect what are the abnormality of the assist. For the radiologist, he can easily diagnose the disease, like this is a cancer, this is a fracture, these are the neurological disorder. So we can more accurately, we can use this AI to detect and diagnose it. So maybe that we can use this healthcare. And apart from this, I'm just thinking about the surgery for the robotic surgery. So I think nowadays it is maturing about the surgeons use the robotic system with AI capability for we can minimally invasive surgeries. So this system can offer the precision and beyond the human capabilities. That's what I can maybe thinking of this robotic surgery, and maybe we can go for the research, especially in the medical research. So AI can help to researcher to sift through the vast data set to identify the pattern and the potential treatments we can do for this epidemiology treatments trends. So this can be accelerating the medical researchers, and moreover, especially for the ChatGPT can help you to understand if we have any detail over there, it can provide the description about what is the disease. So what are the defects. So all the things you can able to through this ChatGPT. This can be one of the learning platform to you can given, because this ChatGPT has been trained with a vast variety of data, so you can ask any question to the ChatGPT, you get knowledge over that. This can be helpful for the new doctors. They can understand if they want to newly understand the system, instead of depending on anyone, this ChatGPT can help you with more insights over there. So
thank you. So you pointed out the advantages that it will have in diagnostics, especially where the images are important, where the digital inputs can come in. You talked about the advantages that may come in therapeutics, in diagnosis. Clinical diagnosis may also be assisted by the huge inputs that there are. Then you talked about the therapeutics which could change. You talked about surgery and the robotic surgery with all the inputs that come in may become finer than what a surgeon is able to achieve with hands. And you've also spoken about the role in research. So I think we'll have the inputs from Mr. Gurbaran as well before we get our experts to talk about the huge literature that has accumulated in ophthalmology. So I think Dr. Apoorv and Dr. Bali and all of you can then put in inputs with regard to ophthalmic one. So Mr. Gurbaran, what are the medical uses or ophthalmic uses which you have seen and which you foresee in the coming future?
To augment the comments, right?
Your voice, can it be a little better? We somehow.
Is it audible? Is it audible?
Yeah, but the clarity is of sound.
Yeah. As Anand said, right, AI can certainly revolutionize, the health industry given the data availability, right? So right from training, research, even end of life care, right? Like even robots can assist, patients, during end of life care and treatment, decision making, and two areas, right? Like one is in training, right? Training area is something, if you want to do some augmented, virtual reality for the simulation, if you want to, try a surgery, right? If you don't have, other logistics, you can try with the simulation. So that is one area that AI can make a great impact. And personalization of treatment, okay, which is something was not possible, due to the non-available data. Now you have a very detailed list of data. Through that, you can handcraft a personalized treatment for each of the individuals by going through the individual records, right? By going through various parameters, X-rays, whatnot, right? And especially for the ophthalmology, right? There was one use case by Google. Okay, it is automated retinal disease assessment. Okay, this is for the detect diabetic retinopathy, right? So this for this they've used 100K plus data sets to train a computer convolution neural network, which is basically a neural network to identify things on image, make insights on image, right? So they had some curated 100K data sets with de-identified data sets, and they trained, and they were able to achieve phenomenal results with their training. And so this can be used in countries wherein the medical resources are very, very less, right? This can be used as a non-hospital areas, can be used, even a trained physician can use this solution to identify whether a guy has got this retinopathy or not, right? So this is just one example. Similar way, breast cancer, right? Breast cancer for ladies has to go to hospital and they have to get that tested. But because of this advent of this app, right, in the mobile-driven way, they can do the scan and they can get at least a first-level assessment, right? Yes or no. Based on that, they can further go to the treatment and get it addressed quickly, right? So these are few examples I wanted to call. Okay, but
there is a huge potential of a number of conditions, and I think clinicians have also now collected a lot of literature on the subject in ophthalmology, and we would like you to be here so that you listen to what they have to say on what literature they have seen. And Apur, can you please ask questions related to the clinical ones to this clinician panel about all the literature that you have collected?
Thank you for pointing out the uses in medicine and ophthalmology. Now, as you pointed out, in diabetic retinopathy, we already have an AI algorithm which can quite accurately not only diagnose diabetic retinopathy, but it can also tell us which cases need a referral to an ophthalmologist. So ophthalmology being an image-based modality, you have a number of conditions wherein the AI can help with diagnosis and also to determine whether the disease has progressed over time. Over time, we may have AI algorithms which might be able to look at OCT images to see if there is progression. We might be able to diagnose glaucoma based on optic nerve head images. There is a lot of study on that. It may be able to tell us how the disease has progressed over time, looking at the visual fields, optic disc photographs. It can guide us on the treatment based on that. It can look at OCTs maybe and compare how the AMD, age-related macular degeneration, if it has progressed over time. It can help us guide which treatments, which patients need to be treated vis-a-vis which can be observed. And also another field where we're working on in ophthalmology is looking at certain biomarkers which can guide us about the prognosis. AI with its machine learning and the images being fed into it, it may be able to diagnose some newer biomarkers which might be missed by human eyes, and it might be able to tell us which ones need to be treated more aggressively and which ones have actually progressed and might require a different treatment modality. Now, I'd like our other experts to
let's hear Dr. Bali, and
Yeah,
then we'll hear all of you on.
Very correctly, he's pointed out that the first algorithm that got the US FDA approval was on diabetic retinopathy, the IDXDR, which was Abramov's the algorithm which got patented. More recently, we've had another one called IART, which is driven from the iNuke technologies. There are certain other in pediatric cataracts, they've been able to actually predict the visual axis opacification. There's something called the CC cruiser, and based on that, they've been guiding their patients. Something called a CC Guardian. These are things which they've already commercialized. And then, of course, Apoorv's already talked of in glaucoma as it is, its structure, function, and a hybrid approach. And then, of course, the genetics aspect of it. So based on that, there are the studies have been classified into whether you can diagnose them, or you can diagnose the progression, or you can predict. So there are studies based on that.
So there are already a huge number of studies.
Huge,
a lot of large companies are working on this aspect now.
So what we
and with the Google coming into this and some mega corporations coming into this, there's going to be a revolution. You recently heard of what Google said, that they can predict the risk of senile dementia or Parkinsonism on the basis of images, now that they have collected the data. So there'll be a lot of systemic conditions which will be diagnosed on, because eye is an area where you can get images and so on and so forth.
So actually they did not, that's a classical example of serendipity. They were doing something else, and this was the secondary outcome criteria. The secondary outcome, they found that they could predict much better. So like while you have two or three, we always see area under the curve, AUC. So the AUCs are very high, but the positive predictive and negative predictive values were low. Now there is that dichotomy which is still there. So how much prediction is possible is probably.
So false negatives, false positives, all those are important to be seen. Ritin, let's hear you.
So, to add to that, right, one is that there are models specifically handcrafted for health industry, right? The models are very specifically learning the health industry terminologies that are being started rolling out. And one point is that right now we are at the age of artificial weak intelligence, right? Wherein that only cancer or retinopathy is being detected, right? Given the task, right, is doing one. When we achieve the AGI, right, artificial general intelligence, that's when AI, perform, on par with human intelligence, right, wherein it can go through multimodal data, right. As a doctor, you go through multiple procedures to arrive at a conclusion, right, diagnosis. Same way, it can go through multiple modal data. It could be video, image, audio, two-dimensional data, or whatnot, right. Everything put together, it can make a very holistic diagnosis. That is when we approach AGI, we are on course to that. But when we approach artificial superintelligence, right, that's when machines supersede humans. It can even bring on patterns which even our mind cannot, reach. So yeah, certainly healthcare has got very great potential, when it comes to leveraging your AI.
So when we get to artificial superintelligence, I think the ethical questions and all those will also come up. But let's first hear.
I was just asking one small question. Like what you say is that what I understand is that there will be a data, then there will be a patient's that patient. In the background of that data, we have a patient, and then there are other multiple algorithms that they will decide कि भाई इस case में ये कर सकते हैं, ये these are the person. Like based on all the collective data, we come out with the right solution for that particular kind of a patient. Is that right? Now,
exactly.
I'll just complete that. So in that case, there will be multiple companies might be coming out with their own kind of a solution to a particular problem. So now then there will be a competitive market sort of thing. Are we expecting that? And then there can be certain fallacies and more market-based and more misguidance, and then there can be lots of confusion. Instead of getting something positive, we'll end up into something negative. Are those possibilities exist or no?
Sir, actually artificial intelligence is a very dynamic process and a dynamic thing as of now. What you're saying is all correct. US FDA has realized this, and now what they've done is they've allowed something called SAMD, that software as a medical device. So they have tried to address this particular issue, that there will be a stage called a pre-certification stage. So there will be a pre-certification stage, and then there will be a post-marketing phase.
So a lot of data may come into your machines, like your OCT machine will be a more intelligent machine. It will, on the basis of patient's data, interpret it in the light of all that it has gained from its artificial intelligence, and may be able to give you many, many more inputs than what you interpret now. It may be able to detect even many more better things, much more than what you can observe with your eyes.
Sir, your interface
that kind of things may come up.
It will be a tool or a replacement for us?
No,
it will not be a replacement. It will never be a replacement.
It will never be a replacement. And the best thing is that your interface is not going to change. You are using these IOL calculators. So your interface is going to remain the same. At the back end, in the mainframes, on the servers, that's where all the changes will take place. And whatever is loaded on your machine, or whatever you're taking from the net, you're going to put just the same information. All that information that we're talking of, humongous amount of information collected from patients, algorithms generated, that's at the back end.
So Ritin, please.
So I think AI is the buzzword now, right? For everyone. We think, so my patients, just on a lighter note, every day ask me that, Dr. Ritin, are you going to do artificial intelligence cataract surgery? I just saw on YouTube it's going to happen.
Yeah.
So I tell them that, yeah, we'll be able to do the same surgery. I'm not so sure if it's artificial intelligence or not. Why I'm bringing this up is we need to understand what is artificial intelligence, and I think it's really been covered very nicely, but we also need to understand what is not artificial intelligence. So artificial intelligence is when you allow the computer to think like a human by itself. Not that you are feeding an algorithm to the computer and they are just following your instructions. Then it's not artificial intelligence. If the computer is scanning something and you've already told the computer what to do, then it's not artificial intelligence. The computer needs to figure out what it's seeing and then act on that. And that means that it needs to make its own algorithms. It's not, so when you look at normative database, in so many diseases we already have them. And it's telling you that what is the prediction of whether the disease has progressed or not. This is not artificial intelligence. We've already had this. And whether it's topographic readings, whether it's visual fields, whether it's OCT in the retina. If the OCT is actually able to understand that there is something wrong with the macula, and it starts thinking that what is wrong with the macula, and sooner or later starts telling you that this is what I think that the disease is, or where the disease is coming from.
So these are the different levels of
that's when
AI.
it's going to be AI.
Yeah.
It's not going to be AI if it's just telling you progression. Am I right? Maybe the experts can add.
Excuse me, just one thing. See, maybe Dr. Anand Raj and maybe Dr. Gurbani can correct. You see, what's happening is, we know only the medical aspect, that what we know. See, there's a lot of things going behind. There's nothing that computer is generating itself. It's a piece of metal at the end of the day. So it will only interpret what you feed it. And what is being fed in is, we know only 1%, 99% is being fed in by the mathematicians and other branches which take our data, interpret, process, and then feed it back into the computer the right way to get the right result. So that's the way it goes. When the computer doesn't generate anything of its own.
So there are two ways of looking at it. One is, like Ritin said, if we write a program that if it is X, then you have to do Y. That's a program. That's a computer program. That's not artificial intelligence. When is it artificial intelligence? You've labeled the data, and while the patient comes and sits, and it simply says, okay, this patient is now this, right? It is actually picking it up from its own database, right? It is picking up from the database, but it is doing it almost real time, and it is identifying it. So basically what you are talking of is, that's what Guru was talking of. You know, we are in the era of what is called artificial narrow intelligence. Whatever we are teaching, the machine is becoming better and better in that field only, right? It is not that if it has learnt chess, then it will become good in ophthalmology. No, that is called transfer learning. Once it is able to do transfer learning, then it becomes artificial general intelligence. That means it becomes like human beings. It will be able to process the context in which the data was collected.
Those levels where all the ethical questions will come in. Veronica, so super intelligence and then beyond, there are other levels which are yet to come in, like, but singularity and so on, which will pose a lot of ethical questions and are being regulated. So Veronica, what do you have to add?
Yes, sir. So one is about ChatGPT. It's an excellent tool. I think I have extensively used it in so many things, to write papers, etc. I think we all must use it. So it's a very common saying now that AI will not change the world. People using AI would change it. So it's actually us who will use AI, and we will be much more efficient, quicker, and work better for it. And about the Alzheimer's and dementia, what we were talking about, in addition to the imaging, now we have genetic markers called SNPs, single nucleotide polymorphisms, which can be tested to know our risk of diabetes, hypertension, Alzheimer's, all the multifactorial disorders.
Bhupesh.
So I think I agreed with Ritin. We have the machine that have the data-based results, but once machine starts learning itself, then that will serve the purpose, real purpose.
And that is iterative self-learning. That is machine learning.
So currently we are in a stage where we are using the machine to do all the work faster for us, including pick up patterns. So the data we're feeding it, we are also asking it to pick up a pattern and identify a disease which maybe would have taken a human or a lot of humans years to pick up, and it can process those millions of images and identify what little difference is there and be able to identify a disease or give us a predictive value. So that's the current use, and well, I hope we never reach a place where our brain can be
you were
replaced.
talking about some plans that you have for the utilization of AI in your future projects. So what is the area?
So I work in neuro-ophthalmology, so we're still working on disc edema interpretations. We had this work with, of course, retina colleagues where we had done for ROP. So there was an ROP AI system that has been in place with IIT. So the whole thing is working with IIT where we are looking at, for me, I'm looking at disc edema, but in whole RP center, there's a lot of AI-based different sub-areas are working on for identification of disease.
So can you name a few?
So corneal disorders, corneal dystrophies, like I said, ROP, diabetic retinopathy, of course, but that's been done with such deep pockets that nobody individually would ever, dare to compete with that. And like I said, disc edema. So the same thing that we're talking about, we're giving them a lot of images, the machine learns, then starts getting better at when we start giving it unlabeled images, and it is able to identify and then be able to pick it up much better and identify things in those unlabeled images which I as a human I am unable to. So it gets better than me, faster than me.
And so interestingly in ROP, it is not labeling of the data as such. There what it did was, this was pre-AI days. ROP, like the RISA and the vessel tool. So the vessel parameters, they started measuring the vessel parameters, and subsequently when AI and labeling came, they found that those parameters became the predictors.
So Dr. Balla, please.
I think artificial intelligence is the in thing. Like Ritin said, we are already using in better calculation of IOL power calculation in Hill RBF, Kane formulas, newer formulas, which are giving better results, better refractive predictability within plus minus 0.5 diopters, so that we can really give emetropia to our patients. Even in glaucoma, like you said, there is deep learning and superficial learning. Superficial learning, we are just giving small, the not very difficult data like intraocular pressure readings at various times of the day. And deep learning, where you are giving OCT images and perimetry so that you really know whether patient is progressing or not. And one field where I really want them to make impact is differentiating all those patients we label as suspects primary angle closure suspects, OHT patients, open angle glaucoma suspects.
So
we want to really
lot
get
of
rid of
inputs
that category.
will help,
They
yeah,
are
reduce.
either diseased or they are not diseased. That suspect category where both the doctor is not sure, patient is not sure, I think that category will be slowly out once.
So I
this
think there's a
artificial
very
intelligence may be
big
helpful.
study going on ASOCT, specifically on the suspects.
Yeah.
Dr. Rajendra Prasad.
What I could understand with the artificial intelligence is the quality and the amount of the data which we are going to put in. And finally, it's going to help us in making more accurate results, faster diagnosis and the management. And it's going to help us to use it on a large scale, the population base, because it's not the patient-centric, like one-to-one patient-centric. We can, as a physician, I can give time and diagnose that patient and manage that patient. But at a large scale, using the artificial intelligence is going to be a larger help.
So there will be revolution in multiple areas.
Multiple
Clinical
areas,
diagnosis, clinical therapy.
Yeah, as we have seen in a diabetic retinopathy, the specialist is sitting at one place, and then he can connect all around over the India and then get the data and give the diagnosis. That is one thing. And the second important thing, what I think is with the better quality of data, as Dr. Bali has said, and the amount of the data which we are going to put in, is going to reduce the error, the amount of the threshold of the error, because what I believe is in the coming time, the error is going to be much, much better than the human error.
So apart from...
it's going to, because the threshold, what I understand, the human threshold is around 5%. But the computer or the AI generated error is going to be much better than this, because it's going to improve. It's going to be a super intelligent human being.
So people talk of personal medicine. I think much better thing to talk of is precision medicine. I think.
So Mr. Anandraj, with all the perspective that you heard on ophthalmology inputs, what is your word on how you see a practice of a clinical subject like eye medicine, eye surgery, eye diagnosis change with the AI inputs or the multiple levels of AI that are coming up? We'll have that word and then a few words from the moderator. And I think a much awaited dinner, and sorry for having delayed you all, but I think the subject was so absorbing. Mr. Anandra.
Yeah. So I'm just seeing this, the field of ophthalmologist, so how that AI is going to significant contribution. So what I was done some research before this meeting. So let's say example, since I do have a glaucoma, so I know the Bali, I was working PM actually. So glaucoma management, I think I would say like AI can assist in the early detection of the glaucoma, and it can monitor its the progression. What is the progression for each and every phases? And by analyzing we have field test, right? I think you guys have the visual field test, and using the other data, we can easily early detection of the glaucoma. This can be definitely helpful for the ophthalmologist to make the informed decision about the treatment. So what we can do this one.
So it will improve clinicians' diagnosis ability to pick up cases. Anything else that you think in future will come up which might change things drastically for him? In therapy or in surgery or?
I think maybe we can go for the patient engagement. Maybe I can think of right now. So the AI can driven apps can use tool to can engage the patient in their eye care by providing the educational resources and so reminder for the appointments, and those things maybe we can do for the better manner actually. So right now we are doing, but AI based the engagement, patient engagement.
A lot of other things in clinical practice as a whole will change because of the AI coming in. So thank you both for such important inputs for us, helping us understand AI, the levels of AI and what exactly the jargon means. Thank you so much for all your inputs. Thank you. And Dr. Apoor, will you sum up, and if there's anything from the audience, then we'll take. Yes, please.
No, it's going out actually, it's on YouTube also.
I feel that they are
different aspects of AI, in good way also in bad way. As clinicians, we still have to see the funders and we have to pay. Maybe we'll get a differential diagnosis. We still have to think it is not a machine who is treating a patient. So everything has a good and a bad thing. As Dr. Veronica said very truly, we have to guide the AI. AI can't guide us. We still have to...
Very truly said, ma'am. It is just it's an assistant. Yeah. Like you have a Google assistant.
There are a lot of times I have to call Apoor and we have to have some discussion or otherwise. So maybe that time when you are busy in your OPD, you can think a little more in a vaster way because you have a lot of differential diagnosis. But it is not just pinpoint thing that yes, AI is saying that. And
no. See, what it's doing is it's going to do it at a much faster pace.
Right, correct.
And you pick up from
there. Yes,
so,
absolutely.
So actually, in our discussion, I think we have just touched the tip of the iceberg. There is a lot of huge things that if you go through the literature, you realize how much things are going to change that we can't even see very well from our limited vision.
So with 5G already available, if the latency goes below 200 milliseconds, you'll be doing live surgery 600, 800 kilometers away.
Sir, just a very small point is, as Dr. Veronica mentioned about gene therapy and how it's reserved for the rarest and the most severe cases, I think AI is going to be the reverse. It's going to be a screening tool which will it'll make a lot of mistakes, but it'll be covering a huge amount of population with a lot of general, lot of basic diseases. And it'll help us in finding early diagnostics, early referral, early seeking. At least it's going to start from there. Yeah. And then it gets smarter.
So that we can give more time to the patient because interaction becomes more. So your diagnosis, you are already helped by the machines. You have everything, all the features with you, and you give more time to the patient because that is most important. Exactly. But nowadays what we are doing is like we're not giving time to the patient because we're just looking into here and there, and the patient, hardly 1 minute is given to the patient. So I think this part is very, because the human interaction with the patient is what is most important.
And will remain important.
And this we have learned from Dr. Grover, because the way he deals with the patient and deals with the residents, like he gives so much of time. So I think this makes a lot of difference in your treatment process of the patient. So artificial intelligence, AI is definitely going to help us, but our approach is more important.
AI ko sue kaun karega?
Yes, AI algorithms at the moment are far from perfect actually. So they are there to guide us, but we cannot depend on it 100% as of now. And yes, so it's more to guide us than to determine the final outcome, and we still need physicians for that.
So the US FDA is trying to answer that one under the SAMD only. Software is a medical disease.
So I think with that, we will thank all the panelists, especially our guests, for non-ophthalmic guests, Veronica, for all her inputs, our two experts on AI, and all our fabulous ophthalmic colleagues who have given such wonderful input. But nothing would have been possible without this fabulous audience and IHC and our growers who have done a wonderful audiovisual job. And certainly Allergan Pharma for having supported this and taken the initiative to do this program. Thank you all so much. Thank you, audience. Thank you very much. Hope there was something useful somewhere for...
ये तो यहीं छोड़ना है ना?
ये यहीं छोड़ना है।